والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good afternoon, everybody, and good morning to other colleagues who are joining from other area, and good evening to the others. I am Dr. Mohammed Al-Sineid. I am the chairman of scientific committee of this symposium and the vice president of Saudi Society of Nephrology and Transplantation. On behalf of my colleague, I would like to welcome all of you to the second day of Second Advances in PD Symposium. This symposium is organized by Saudi Society of Nephrology and Transplantation in collaboration with Baxter Company. And this symposium is sponsored completely by Baxter Company. So I would like to take this opportunity to thank my colleague in Baxter Company for sponsoring this scientific meeting. Dear friends and colleagues, I have to tell you that the preparation for this symposium was started more than 6 months ago, and the scientific committee worked very hard to come out with such an attractive program. So I would like to thank my colleagues, the member of scientific committee, for their support and advices, Dr. Khalid Al-Hassan and Dr. Ahmed Mitwalli. Also, I would like to thank other members in Saudi Society of Nephrology and Transplantation Office, Engineer Nihad and Mr. Sulaiman and Mr. Amir, for their hard work and great effort. This program is accredited by Saudi Commission for Health Specialty for 12 CME hours. And the program of this symposium is so attractive. This is why more than 13,000 participants registered in this symposium. And more than 6,000 participants attended yesterday, the first day of our symposium, through the Zoom platform and YouTube channel from all over the world. Before the end of my welcoming remark, I would like to thank all the speakers and the moderators for accepting the invitation and for their participation in this symposium. And also I would like to thank you all for attending this scientific meeting. And also I would like to thank our colleague, Event Troop Company, for their technical support to this meeting. At the end, I hope all of you will enjoy this scientific activity. And before I conclude my opening remark, I have an announcement. There is a minor changes in the scientific program, which is the Industrial Symposium by Baxter Company will be today instead of yesterday at 7 p.m. Riyadh time. So I encourage everybody to attend such an activity. Without further delay, I would like to ask Dr. Edwina to share her slide and Dr. Abdullah Salloum to introduce Dr. Edwina and to start the meeting. Dr. Abdullah, the mic is yours.
Thank you very much, Dr. Muhammad. Thank you. Dr. Edwina, your slides ready. So I'll just give me a few minutes just to introduce you because we have young doctors who like to know you. So ladies and gentlemen, assalamu alaikum. My name is Abdullah Salloum. I am a professor of pediatric and pediatric nephrologist at King Saud University, Saudi Arabia. Today, it's my pleasure, a great pleasure, in fact, to introduce to you Professor Edwina Brown. Professor Edwina Brown is a well-known nephrologist and authority in peritoneal dialysis. She's a consultant nephrologist in the Imperial College Renal and Transplant Center in Hammersmith Hospital, London. She's a professor of renal medicine, Imperial College, London. Her main clinical and educational interests are peritoneal dialysis. She has published extensively in peritoneal dialysis, and she is the author or editor for several books in the field of renal failure, mashallah. We are fortunate today to have Professor Edwina Brown, who chaired the group updating the ISPD prescription guidelines in 2020. I'm sure many of you read that guidelines, which modified the 2006 guidelines to be a person-centered team decision, which is very suitable for us as pediatric nephrologists. Professor Edwina, it's my great pleasure to invite you to start your session, please. Can you unmute, please, your Professor Edwina?
Yeah.
Yeah, can you unmute? Okay, now we can hear you.
Yeah, sorry about that.
Okay, you can start now.
Okay, so I'm going to be talking about the new prescribing guideline. And thank you very much for the invitation to come and talk to you. One day I hope to actually make it to visiting Saudi rather than just talking to you on a screen. So I'm going to be talking about the new guideline that we published earlier this year. So we started thinking about this guideline in about 3 years ago now, and we met at the ASN, and we formed a global group, and we discussed the previous guideline, which was in 2006. We discussed whether KTOV should really be the target, and we decided not. We thought that PD populations had changed since 2006, when the original guideline had been written. We have older and more multi-morbid patients. There's an increased use of PD in lower and middle income countries. But we did have to face the situation that there's very little high quality evidence. So we did not come up with lots of grade 1A statements. It was much more recommendations in an overarching paper accompanied by lots of other papers substantiating our statements, and they were all published in a single issue of Peritoneal Dialysis International. So our first discussion was, should we really be talking about adequacy, which is a term that I think is only ever used in dialysis. We never talk about adequate treatment for anything else. So adequate means satisfactory, tolerable, acceptable, etc. But do we really just want to be adequate? So the first decision by the group was to ditch the term adequacy, and we updated our recommendations to be called prescribing high quality, goal-directed peritoneal dialysis. Now, at the same time as we were beginning to have our discussions, KDIGO had a meeting, which was in Madrid, which I was fortunate enough to be at, which was also talking about goal-directed dialysis, really much more in the hemodialysis world than PD. And they published the deliberations of this workshop in Kidney International at the end of last year. And as you can see, they divided the various things that impact on the functioning and well-being of people on dialysis into those on the left, which are in the blue, which are directly affected by dialysis treatment, and in the green, where it's not really, however you prescribe the dialysis is not going to impact on those outcomes. So for example, ability to adhere to medication is not going to be dependent on how you prescribe the dialysis, whereas anemia management very much is going to be determined by dialysis. So we came up with similar things in peritoneal dialysis. We thought about the factors that were affecting outcomes of people on PD. So things like multimorbidity, the age of the patient, things that were really directly dialysis related, such as symptoms, polypharmacy, volume status, and then all the psychosocial aspects of life, depression, anxiety, financial stress, social support, loss of employment, and reduced time for life participation. And those are going to have a major impact on the well-being of people who are on dialysis. So the themes that emerged from our original conversations were problems using small solute clearance as a target, dialysis-related factors such as volume status, residual kidney function, other biochemistry, person-centered care, which included shared decision-making and quality of life measures, and non-standard PD delivery, such as incremental PD, frail and palliative patients. Now, I know that Isaac Teitelbaum spoke to you yesterday about the first two themes, so I'm going to be concentrating on the more holistic aspects of the guidelines, so namely person-centered care and non-standard PD delivery. But I am going to reiterate the primary recommendation of this guideline, because I think, you know, understanding that is really absolutely key to the way we look after our patients on peritoneal dialysis. So the overarching statement was that PD should be prescribed using shared decision-making between the person doing PD, their caregivers, and their care team, with the aim of achieving realistic care goals to maximize quality of life and satisfaction for the individual, minimize their symptoms, and provide high quality care. Now, we never said that you shouldn't measure things like KTO/V, but I regard things like KTO/V as like a dose. So we don't measure blood pressure control by the dose of the medications that we use, and similarly for peritoneal dialysis. We also, in the guideline, did not say how you should actually deliver the peritoneal dialysis. And so it's not a recipe book, that in this situation you give X number of exchanges or X number of hours on a cycler machine. And that's because the PDOP study has shown that the way PD is actually prescribed in different countries varies immensely. So the graph on the left shows that in the 6 countries that are in PDOPs, for example, in Thailand, 95% of people are on CAPD, whereas in the US, only 17% of people are on CAPD, the rest are on APD. And even within individual countries, the graph on the right shows this huge variation within centers as to how PD is prescribed. So there's no one way that you're doing it should actually deliver PD. And what we said was that PD can be prescribed in a variety of ways and should take into account local resources, a person's wishes regarding lifestyle, and the families and caregivers' wishes if they are providing assistance. Now, this painting I use often when talking about guidelines. It comes from a hospital in Siena, which was built in the 15th century. And in this building, which was still used as a hospital until the early 20th century, there's the main hall has got these beautiful frescoes on the walls. And this is one of them, called Care and Government of the Sick. And what I think it shows is, here's your patient, here are you as the healthcare provider. This is our responsibility. We're here to look after this patient and provide the care that is going to maximize his quality of life, make him better, etc. Behind him are all the busybodies of the guideline writers. And yes, we should take account of them as guidance, but they shouldn't dictate how we deliver that care to the individual. And as we've already alluded to, The whole thrust of the new guideline is person-centered care, trying to deliver the care that is going to enable that person who's on dialysis to achieve the goals that they want. And to be able to do that, we need to be able to take into account so many different factors that as healthcare providers, we're often completely unaware of. So in this rather wonderful painting by Chagall, you know, here's the individual, he's got his religion, he's got his hobby, his violin, you've got the city behind him where he lives, the cow is probably his livelihood, etc. So there's all these different factors are going to be playing a role in how somebody will adapt to dialysis treatment. So in the accompanying papers to the main guideline, Peter Blake and I wrote something about person-centered PD. And what we said was that education is absolutely key. People doing PD should be educated and given choice as far as possible concerning the PD prescription they receive, and they should be educated about their condition and be informed about their prognosis and given opportunity to define their goals of care. And that we need to somehow or another measure patient-reported outcomes and patient-reported experience. That sounds all very well on a piece of paper, but actually there are, it's not always that easy to deliver. So we did identify various barriers and think of various solutions to delivering person-centered care and shared decision-making. So in terms of the actual person on PD, that they may be in denial, or they may have limited understanding, either because of poor health literacy or because of cognitive impairment. They may be depressed. They may have been a different culture to the primary national one, which can create difficulties, or it could be an acute event, so there's very limited time. And the way to get around that is really communication skills training, training our staff, training ourselves not to speak in jargon, giving lots of, taking the time to actually talk to people and developing some degree of cultural awareness. There are also barriers related to the healthcare team and the healthcare system. So many of us feel uncomfortable about sharing bad news. We haven't had the training to talk about PD or palliative care or prognosis. There's often limited time with people on PD in clinics. There may not be much privacy. And because different people are seeing the patients, there could be lack of continuity. So again, we need to think of ways around these various barriers. And I rather like this cartoon, which was in the British Medical Journal a few years ago, when shared decision-making became a very topical subject. And she's thinking, do I tell him what I want? And the doctor is thinking, do I tell her what to choose? And she may well be thinking about what her priorities are, which are very different to what we think are the priorities for dialysis. So these priorities were identified by the SONG PD project from Australia. And as you can see, these are the top 10 outcomes that patients and caregivers were concerned about. And I would like to ask you to think about how many of these outcomes actually relate to the way we deliver dialysis, the KT, and then, you know, or the dose of dialysis, KT over V. So what the guideline has said is that we should be somehow or another measuring the quality of life by some sort of patient-reported outcome measure. And this should become integrated into our management of people on PD. So we need to think about, you know, measuring their experience, symptoms, etc. But we do realize that this is time consuming, and secondly, the tools for measuring this are not easily identifiable. And part of the problem is that there are actually many aspects of life on dialysis which are going to impact on the person's well-being. And Fred Finkelstein and Marjorie Fu, who wrote the accompanying paper on quality of life and patient-reported outcome measures, identified many domains which are going to impact on people's well-beings. And that, of course, poses problems. There's no general agreement, therefore, on the best PROM that we should be using. In some countries, such as the US, mandate that one particular questionnaire is used once a year, but is that actually enough? Because people's quality of life are going to change more frequently than an annual basis. And as I've shown you, multiple domains need to be addressed. And can these really be measured in one simplistic measure? But having said that, the goal of care should still be adjusting the therapy to maximize quality of life, even though there's still very many unknowns as to how best to do this. Personally, I find that, I just ask people how they are. It's very, do you feel well? How do you feel now compared to, a year ago or before you started on dialysis? What do you find difficult? And if you're wanting to change the prescription because you feel that somebody's losing residual kidney function, start discussing, do you want to increase the number of exchanges? Do you want to change to APD, change the number of days, and really incorporate it into people's lifestyle? And this is where we come into the non-standard PD delivery. So thinking about incremental PD, this is a strategy by which less than the standard full dose of PD is prescribed when starting, with the understanding that residual kidney function contributes to the small solute removal. And then as the residual kidney function falls, the PD prescription is increased. It is not, and I can only emphasize that to a global audience, it is not the prescription of less than the standard full dose of PD because of financial constraints or because of a person is on a palliative trajectory. It has to be with the recognition that as residual kidney function goes down and people start becoming symptomatic, you have to increase the dose of PD. There are lots of advantages to prescribing incremental PD. Firstly, in terms of people starting, if you think of going from a normal life as we are all leading or try to lead into having to suddenly do dialysis, moving from doing no dialysis to suddenly doing 4 exchanges 7 days a week or being on a cycler every single night is a huge step and can be quite devastating to people. Whereas if you can introduce dialysis much more gently using 2 exchanges 5 or 6 days a week is easier for people to fit into their lives, less equipment and boxes that have to be stored, and really makes PD a much more acceptable dialysis modality. These are just some of the regimes that were suggested by Peter Blake, who wrote this particular paper in PDI, that can be used. As you probably gathered, the prescription that I commonly use is 2 exchanges 5 or 6 days a week. Or if the GFR is lower than is down to about 4 or 5, I'd start people on 3 exchanges. I very rarely start people on 4 exchanges. And this is just data from our own unit, which has been published in PDI, where we've practiced reduced intensity PD for many years now, showing that the time to technique failure was much, even when you adjusted for residual kidney function, is much better, as it were, in the low intensity group, which is the black line, compared to the high intensity PD group. Moving on to the old and palliative group, I rather like this cartoon by Goya, which he did when he was 83, I Am Still Learning. And again, we have an accompanying paper, which I wrote with Helen Hurst, who's a specialist nurse in both dialysis and elderly care in Manchester. And we made the point that for people who are multimorbid, got poor prognosis, old and frail, PD is only one component of overall care, that we need to think about geriatric and palliative care assessments, that management really should focus on quality of life and symptom control, take advantage of the fact that people have got residual kidney function to really reduce the PD prescription, and that the goals of care should be determined by shared decision making. And we produced this table thinking of the many different aspects of frailty, which are going to impact on the management of doing PD. Now, I'm not going to go into these now because my next talk is on older and frail people. So coming to the end of the talk, although we have not identified one single measurement that is going to tell you whether somebody is thriving or not on dialysis. There are no targets, but it's multifactorial. So is somebody, what's their well-being, what's their volume control, what's their solute removal, and what non-dialysis factors are contributing to things. And that based on these, we would then make a decision about, do you need to increase the dialysis delivery? And these are just some examples of the individualized prescriptions that can be used when using this guideline. So incremental PD and frail elderly we've talked about. Equally, people who go to work, I have patients who do a mixture of CAPD and APD, so that depending on whether they're traveling for work, whether they're at home, etc. And to finish off, this is the pictorial summary of the guideline that was used for the cover of PDI, which has the guideline. This is the summary of the 2006 guideline, which really focused on small solute removal and ultrafiltration. And really the emphasis now is shared decision-making, considering local resources, modifying the prescription as needed, preserving residual kidney function, and conforming to resource limitations. We also have a section on children, which I haven't had time to go through, but again, it's really focusing on medical, psychosocial, and financial needs, and then assessing all these different factors to be able to produce the high quality, goal-directed peritoneal dialysis. Thank you.
Thank you very much, Professor Edwina. This is very nice talk and demonstration for the updated ISPD guidelines. If you allow me, we'll have a few questions from the audience. First question from Dr. Sarah. What are the potential risks for incremental PD strategies?
So I think the main risk of incremental is not measuring residual kidney function. If you don't preemptively look at residual kidney function, then you can end up with somebody really feeling quite unwell when they effectively become underdialyzed because they've lost kidney function. So it is really essential to measure it. So we measure it every 3 to 6 months. And I'm sure Professor Teitelbaum, when he gave his talk yesterday, also emphasized the importance of measuring residual kidney function. And also as part of the education conversation with the patient and their family is emphasizing that as residual kidney function goes down, there are, the dose of dialysis needs to be increased, but that can be a choice. If you've started on 2 exchanges 5 days a week, do they want to go up to 2 exchanges 7 days? Do they want to go up to 3 exchanges 5 days? Etc. So it's still a matter of discussing it with the patient.
Okay, good. Thank you very much. That question, in fact, from Dr. Nahla, not Sarah. The other question from the audience, when the PD membrane start to be insufficient, do you prefer a hypertonic glucose solutions or to use a long dual icodextrin solution?
So in thinking about long-term PD, you want to minimize the glucose concentration or the use of high glucose fluids as much as you can, and use icodextrin instead for long day dwells or for volume removal. We have some patients who are losing ultrafiltration or unable to restrict their fluid intake, who we actually use 2 icodextrin in. Occasionally, but there is a cost. Icodextrin is more expensive than dextrose dialysate, and one needs to remember that in some parts of the world, icodextrin is not available or can't be afforded. The other thing to remember is the use of loop diuretics, and which are really very effective at increasing urine output. And that can, again, minimize the use of having to use high strength glucose dialysis solutions.
Okay, thank you very much. That was the first session ended, and we'll move to the second session. I'll give the mic to Dr. Randa Dahlan. Dr. Randa, you to moderate the session.
Thank you, Professor Loom. I would like to first introduce myself. My name is Randa Dahlan. I'm a consultant nephrologist at King Abdullah Medical City in Mecca. It's again my pleasure to introduce Prof. Brown. She's already been introduced by Professor Loom. I would just like to add that Professor Brown has a special interest in dialysis in elderly. She actually has published also in this field, and she's actually the principal investigator for the frail elderly patient outcomes on dialysis study. Dr. Brown will be talking to us now about the role of PD in elderly frail patients. Prof. Brown.
Okay, let me just share my screen. Sorry, I'm just getting up the other talk. Okay, so my other talk is entitled, "Is PD the optimal dialysis modality for the old and frail patient?" So we're all facing what some people have called the silver tsunami, aging populations who and are going to have a much higher rate of advanced kidney disease. And this is the UK experience, and this is going to be reflected in most societies as they become wealthier and the age of the population goes up. So this is the current situation at the end of 2018 in the UK. The highest prevalence of people on dialysis are the very old. And this has resulted in a huge change in the dialysis population. So over a 9-year period, there's been a 40% increase of people over the age of 75, and a staggering 63% increase in people over the age of 85. And here's my cartoon again. I'm still learning. We are still all learning and about the optimal way of looking after the old and frail person who has developed advanced kidney disease. So when we think about choice of dialysis modality, there's never been any good study that has shown any difference in survival in hemodialysis compared to peritoneal dialysis. So the decision therefore should be made with the patient or the person going on to dialysis and their family, and it should be dependent on their goals, lifestyle, and medical concerns. And the availability of assistance enables older people to have dialysis at home. And assisted PD has been available in France, which is the main country which introduced this sort of dialysis quite a few years ago. And in many parts of France, assisted PD is actually considered as the first-line treatment for older and frail patients. And as we've already discussed in the first talk, we really need to think about patient-centered care. So what matters to the person in front of you? Is it travel? Just because somebody's old, they don't not travel. I have many older patients who come from different parts of the world, and they want to go back to their country of origin and see family and see places before they die. Are they looking after their spouse? Are they responsible for grandchildren? Are they more interested in length of life or quality of life? And what are their end of life priorities? So if we think about hemodialysis or peritoneal dialysis in the elderly, let's think about it from the patient perspective. So for hemodialysis, they have to travel to the hospital, which is going to add to waiting time, journey, etc., and needs to be added onto the treatment time. But because it's a hospital-based treatment, it's not dependent on the person's ability to be able to actually do the dialysis. And for quite a few people, it does provide a social structure for the frail elderly. So I would like to suggest that actually going to dialysis 3 times a week is probably not as enjoyable as going to a social club. They often feel completely washed out for hours after a hemodialysis session. It's going to interfere with social and family life. They need repeated surgery for vascular access, and it's going to be very difficult to travel. Whereas being on PD, it's at home, gives them independence. It fits in much better with any social activities. It can be done by a carer or a paid assistant. Many less visits to the hospital. There's huge flexibility of exchanges and the way you can deliver PD, so it doesn't need to be presented as 7 days a week treatment. But there is a treatment burden related to the repetitive nature of performing the exchanges. And as I've already shown you, that is improved by having days off, and it's much easier to travel. And in the current era, there's a much lower risk of acquiring COVID if you're on PD compared to hemodialysis. And certainly we are seeing in many centres in the UK, and certainly in my own, a huge increase in the numbers of people who are choosing peritoneal dialysis at the current time. And one of the big advantages of peritoneal dialysis is that you avoid what I call the vicious cycle of ultrafiltration and loss of residual renal function. So you go on hemodialysis, you get intradialytic hypotension, loss of residual kidney function, which has problems with weight gain, increased ultrafiltration requirements, etc. And this also has an impact on cerebral blood flow. And this study of measuring cerebral blood flow actually during hemodialysis using PET-CT scans showed that people over the age of 65 going on to hemodialysis having a drop in cerebral blood flow during their dialysis. And I would like to ask you, how many of you would like to go on a treatment or suggest that your parents should go on a treatment where their cerebral blood flow decreases 3 times a week. And not surprisingly, this has an impact on cognitive function. So this study done by Tamura, that was published in Kidney International, where they measured executive function in people with GFRs of less than 20. Some of them had never went on dialysis. Some of them had baseline and then went on to hemodialysis. And then some people who were always on hemodialysis. And as you can see, people on hemodialysis or who started hemodialysis during this study had a drop in cognitive function compared to those who didn't go on dialysis. This is our own small study where we compared people from before they started on dialysis to going on hemodialysis or PD. And this showed that the MOCA, the executive function on the MOCA scale remained stable in the PD patients and declined in those on hemodialysis. So the benefits of PD for older patients is that the treatment's at home, the flexibility of treatment around social activities or at night with daytime freedom. It enables travel. You preserve residual kidney function, enabling days off dialysis. There are no hemodynamic swings and no periods of feeling washed out as you get on hemodialysis. And it's a simple procedure, so it can be done by family members or a paid assistant. And this is another study that I came across in PLOS One, looking at people who went started on hemodialysis and PD from low clearance clinics. So they had data from before they started dialysis to when they were on hemodialysis or PD. So let's look at the bottom line here, where people from a GFR of less than 10, if they chose conservative care or no dialysis, they had many less outpatient days than those on dialysis. But if you compare hemo and PD, again, many less days for outpatient care and PD compared to hemo, less days for inpatient care, and so total hospital days are much less on PD compared to hemo. There are, of course, potential obstacles to PD for older patients. And really, it's the features of getting older: poorer manual dexterity, impaired physical function, impaired vision and hearing, cognitive dysfunction, general frailty, etc. And all of those can be got round by using assisted PD. So in the UK, the way we deliver assisted PD is using a daily visit from a healthcare assistant. This is how we set up the project now 15 years ago. We don't use a nurse, we use a healthcare assistant who is somebody with really minimal training. You don't need a nurse because, after all, patients and their family members are not nurses, and they manage to do dialysis. The healthcare assistant took the bags off the cycling machine and then set up the machine with new bags, checked the patient's blood pressure and weight, and the patient, with or without family support, did their own connection and disconnection from the cycling machine. This obviously limits the use of assisted dialysis. And these days, we can now get 2 visits a day for assisted PD, either for connection and disconnection visits onto a machine, or using assisted CAPD, but 2 exchanges a day. So what's the research evidence for older patient outcomes on dialysis? And I'm going to share the information with you from 2 studies that I've done over the years. The first one was the BOLD study, which was published in 2010 in nephrology, dialysis, transplantation. And the second is the FEPOD study, which was published more recently. So the BOLD study was done where we matched, we had 70 patients on PD who were over the age of 65, and they were all matched to people on hemodialysis or rather the hemodialysis patients were matched to the PD patients by age, gender, length of time on dialysis, and postcode deprivation. And we did various quality of life measures and showed that in terms of illness intrusiveness, that was a lower score in people on PD compared to hemodialysis. The BOLD study was done in an era really before assisted PD had really started taking off in the UK. So we repeated that study later on and published this in 2016. And this was the FEPOD study. And again, it was 129 patients on assisted PD. Some of these were family assisted, some of these were assisted by paid assistants. And again, hemodialysis patients requiring transport were matched to those patients. And what we found was actually that frailty was the predominant association with all the various quality of life measures, though renal treatment satisfaction, which is going to be a measure of burden of dialysis, was lower in the hemodialysis group compared to the PD group. We also did a longitudinal part component of this study. So people were followed for 2 years. I learned a lot doing this, and I would not recommend anybody doing longitudinal studies. The statistics become very complex as so many people drop out from your study, particularly in this age group. But what we really found, and many other longitudinal studies have shown the same, is that various quality of life measures actually remain very stable over the 2-year time period. And remember, these are going to be survivors and not the people who are dying. So going back to the concept that it's frailty that is the predominant factor that is associated with outcomes, does actually dialysis benefit this group of people or not? So these are studies that were done looking at survival in people on PD, choosing conservative care to those choosing dialysis. And what this shows is that those who had low comorbidity, yes, going on dialysis extended your survival. People with high comorbidity, people on conservative care and renal replacement therapy really had the same survival. And then similar data in people over the age of 80. If you were less than 80, you had better survival on dialysis compared to conservative care. If you were over 80, survival was very much the same. So this then comes to personal choice and also trying to tailor our treatment to the individual in front of us. And every older person is different. So this painting by Rembrandt shows painting of an older man who's reflecting on his life, and he's been quite successful. He's nicely dressed in red velvet. And this painting's in the Hermitage in St. Petersburg. This painting by Van Gogh is in a museum in the Netherlands, and the title is actually that provided by Van Gogh, Sorrowing Old Man at Eternity's Gates. So many older people realize that and appreciate that they are in their last stage of life. And this painting shows that for many people, old age is not a happy experience. He's depressed, as shown the fact that he's in blue. He's probably poorly nourished, he's poor, his room is empty, and he's lonely. And we really need to be aware of the limitations of dialysis and the overall prognosis of the person that we're treating. And this painting by Krenach, which is in Berlin, shows the old and decrepit going into this pool, coming out young and beautiful. And many people regard dialysis like this. I've looked after people, when you ask them why they're starting on dialysis, I always remember one man who was in his early 80s, who'd had a stroke 10 years previously, was in a wheelchair. And I said, why are you wanting to start dialysis? And he said, so I can walk again. We really need to be able to set realistic expectations with our patients. And one thing that we don't know is how much dialysis do the old and frail really need. So, but one thing that's absolutely certain is that this old lady in the wheelchair is going to need considerably less dialysis than this rather overweight journalist. And there are certainly no peer-reviewed articles that are going to give us any guidance. So when we think about dialysis in the frail person, we need to really think about hemodialysis as how many hours, think about the intradialytic hypotension and what that's going to do in terms of residual kidney function, what it is going to do to their heart, what it's going to do to their brain. You need to think about transport to and from dialysis, time to recovery, etc. I mean, in PD, you need to think about how can you reduce the dose, individualize that prescription, because they've got residual kidney function, which, as we all know, in older people tends to decline much slower. Think about, can they really learn to do it, or are they going to need assistance? And so I've set up this program of doing 2 exchanges a day, often for only 5 or 6 days a week. So we use this in the frail people with residual kidney function. Some of them have got heart failure and volume overload, and we would then use 2 icodextrin, but mostly it's either a 136 and 227 or a 136 and icodextrin. And as part of the education, people are told that it's going to improve symptoms, that they can have a choice about whether they want to continue or not, because you can stop this sort of dialysis, unlike hemodialysis, because they've still got residual kidney function, and that the dialysis is there for symptom control only. So, as I've said, this is can either be done with family members or with a healthcare assistant who comes in, and we have these various conversations. And the other thing that we do at 3 months is to have a conversation where we set ceilings of care. Do they want resuscitation? Would they want to go on ventilators, etc.? And these are the results from after we'd done our roughly first 30 patients, where we had very few stopped, only 2 patients stopped electively, 2 died, and 2 got infections. This is looking at their symptoms. I find that the symptoms that improve quite dramatically is the feeling of tiredness. They all comment mostly about how less tired they are, how their appetite's improved. And because you're using things like icodextrin, you're improving their volume status. And these are just some of the comments that the patients made. Much better since starting PD, more energy, gets out, teaches an art class. He was 89, this chap, and he commented about it was an art class for the elderly, and he was older than any of them. And he was on assisted CAPD, 2 exchanges, 5 days a week, for about 18 months. And then one day the assistant went in and found him dead in bed, which I think is really a lovely ending. So should assisted CAPD replace hemodialysis as the default dialysis modality? There are certain advantages to it. It avoids the hemodynamic swings. It certainly reduces the risk of COVID infection. But it's you've got to be able to provide the assistance, and you need to really think about having these difficult conversations with the patients. And this is my final slide. This is from a museum in New York. this is a candle. And you may just see that there's a light at the end, at the top of him. And there was a notice at the, on the wall saying that this represented life and dying. We're all going to die. At the end of this exhibition, this candle, which was going to be about 3 months, this chap was no longer going to exist. Thank you very much.
Thank you, Prof. Brown, for this very interesting lecture. I think we have a few questions here. I'll read the first one. One of the attendees is asking about if we have any data to tell us about the rate of peritonitis and exit site infection between patients who receive assisted PD versus those who do the PD themselves.
So there's very good data on that from the French registry, which showed that the peritonitis rate was about once every 2 years in the assisted group and about once every 3 to 4 years in the autonomous group. But the assisted group, the peritonitis rate was lower in those where the assistants were being trained by the PD units, and it was high, and the rate of infection was highest where the assistants were just being trained by other assistants. So I think the message from that is that your peritonitis rate is going to very much depend on how well the assistants have been trained. And certainly in our unit, and I think the UK experience in general, because the assisted program is done through mostly through a centralized system, which has been set up by Baxter with a national healthcare agency, and Baxter does the training. So the assistants are well trained, is that the peritonitis rate is no different to our usual patients.
Okay, great, thank you. The second question is there any survival benefit of PD compared to hemodialysis if we adjust for frailty?
Again, there's no data, but again, using the data from the French registry, they published a cohort of patients. I think it was a few years in that, but they looked over a 5-year period, and it was in about 1,500 patients all over the age of 80. And their median survival, these were people on assisted PD, was over 2 years. It was about 24 months. And I compared that to exactly the same period for patients over 75 from the UK renal registry. And the UK renal registry would be all comers. So it wouldn't be just the frail people over 75, it was all of them, mostly on hemodialysis, and some because that's only about 10% would have been on PD. And our median survival was exactly the same. So yes, it's quite possible, given the French data, that their survival may be better on assisted PD. And I was certainly thinking of individual patients, who've been on assisted PD for 2, 3, 4 years. You just know that if they'd been on hemodialysis, they would have died long since.
Thank you. So the third question is about what do you think the expected barriers and the solutions to overcome these barriers to set up a home-based program for PD, especially at the time of pandemics like the one we're living right now?
Well, in terms of the pandemic, there's a huge advantage for particularly older people who are very vulnerable to COVID to having their treatment at home. And we certainly are doing assisted PD in nursing homes. Our PD unit has grown by over 30% in the last 6 months of people who are wanting to have PD so that they can stay at home. Their families look after them, and particularly in multi-generation families where the families are looking after them at home, and therefore they do not need to come to the hospital. So it's a matter of education. That's absolutely, you can't develop a home program if you don't educate people and their families who are coming to having to start on dialysis.
Great, thank you. I think we have to move to the next lecture now. I would like to give the mic to the next panelist, Dr. Ali Al-Faqih. Thank you, Prof. Brown.
Dr. Ali,
Yes,
the mic is yours. Huh?
Yeah.
Dr. Ali, the mic is yours. So
Yes.
can you introduce Dr. Raymond?
Yes, I'd like to introduce myself. I am Dr. Ali Al-Faqih. I'm consultant nephrologist in Armed Forces Hospital in Jazan. I am delighted, actually, and deeply honored to present to you Professor Raymond PD. As you all know that he was with us yesterday, and he enlightened us about the encapsulating peritoneal sclerosis. He will speak today to us about the update in the biocompatible peritoneal dialysis solutions. I would like to take this opportunity to introduce Professor PD. As you all know, he is a well-known nephrologist from the Netherlands. He has a wide experience in peritoneal dialysis, and he was the chairman of dialysis group in the Netherlands. He was the chairman, he was the president of the International Society of Peritoneal Dialysis. He is the recipient of the International Distinguished Medal from the National Kidney Foundation in 2012. And he has a long list of publications exceeding 540. So, Professor, it is with honor to present you and to invite you to speak today to us. So the mic is yours, Professor.
Raymond, you need to reshare your screen again. You will be reconnecting again. Raymond, you need to now share your screen again. Raymond, are you hearing us, Raymond? Professor Raymond, are you hearing us?
I think he needs to unmute.
No, he's not sharing anything. He's on mute.
Please accept the request, Dr. Raymond. Unmute. Request unmute.
Ahmed, can unmute him, Ahmed, and let him share the screen, yeah, Ahmed?
No.
No, I mean Ahmed, our technical guy. Ahmed, unmute him and let him share the screen, yeah, Ahmed.
Okay, now.
Yeah.
Now unmute. Dr. Raymond?
Excellent, excellent. Yeah, we can hear you now.
You can hear me now?
Yes, yes.
Okay.
So you just now share your screen now again.
I do that, yeah, sure. I shared the screen, but I need the presentation. This
Excellent.
there we go. Right, is this okay?
Yes, okay, but you need to open the file, not yet opened. Your screen is being shared, but click the PowerPoint, yes.
I click on stop. Oh, you see my slides or not?
We can see your screen, but your slide is not yet opened.
Okay.
You need to just click on it.
On the slide.
Yes, because we can see your file. Just click on it to be open.
Okay.
You are not sharing your screen right now. So share it again.
I'll share again, yeah. Yeah.
And select
okay.
PowerPoint presentation.
Yeah.
Share screen and select PowerPoint presentation.
This should be okay, isn't it?
Yes, okay.
Excellent.
Perfect.
Yes. Just maximize it and that's it. Full screen make it.
Yes, I'll do that. Maximizing doesn't work.
I think should be fine. You can present like this, but
okay. Okay, I'm sorry about that.
Can you click F5?
I'll see what I...
Select F5 in keyboard. F5, slideshow mode.
Okay.
I think it should be fine. If yeah, he's clicking the right click down, but I don't know why it didn't go up. But it should be fine. I think we can see the screen nicely. But start from the first slide.
Yeah, because it does not work.
Okay.
Well, okay. All right. So I will discuss with you about the about biocompatible solutions. And the first thing is that the conventional solutions are rather not very much biocompatible because they are acidic, hypertonic, they have a very high osmolality, contain enormous amounts of glucose ranging from 75 to 215 millimoles per liter, are lactate buffered, and because they are heat sterilized, there's the formation of glucose degradation products. And the aim of biocompatible solutions was to increase the pH and reduce the amount of glucose degradation products. So how is this done? Well, first of all, you have to realize that sterile filtration is not allowed. So what the pharmacy concluded was that it was best to have heat sterilization in 2 compartment bags with the glucose in a very small volume at a very low pH. And this then leads to a dialysis solution with either a higher or a normal pH. Let me. So these are some examples. This is the Fresenius solution. This is the Baxter solution. This is Bicavera. You see that the glucose and electrolytes are sterilized in a separate compartment from the buffer. And the same is done for fishonil, electrolytes and glucose in a separate compartment from the lactate solution, and then before inflow, the 2 compartments are mixed together. Let me see that. well, these biocompatible solutions, here you see the three that are available. You have fishonil, bicarbonate lactate buffered, balanced from lactate buffered and bicavera bicarbonate buffered. Here are the pH values, and this is the content of one of the glucose degradation products, 3-deoxyglucosone. And what you see here is that the fishonil solution has the highest amount of it, of 3-DG, but that is still less than half the amount of dianyl. So that it's really different. What I want to discuss with you has to do with short-term effects and long-term effects. First of all, the short-term effects, and I'll discuss with you the fact that the inflow pain is reduced. I'll say something about biomarkers, peritoneal transport, advanced glycosylation end products in the circulation, residual renal function, and the incidence of peritonitis. Well, let's start first with the with pain. This is already an old study about with a pain questionnaire. Conventional solution had the highest value for inflow pain, and this biocompatible solution was associated with the lowest value. So when we continue, then this biomarkers, there are data on cancer antigen which increases and hyaluronan in effluent that which decreases. Only one study showed this, so I will not discuss it, but a lot of studies showed that dialysate concentrations of cancer antigen 125 increase. Well, what does that mean? You have to CA125 is a protein, mucoprotein, that is used as a biomarker in vivo of biocompatibility. It's a protein, and effluent concentrations represent peritoneal cell, represent mesothelial cell mass or turnover in stable patients. I put here peritoneal, but that should be mesothelial, of course. It's higher during mesothelial mesenchymal transition. Peritonitis is associated with some temporary increase of it, but that's just for a few days. And it is higher with a conventional solution than if it is a biocompatible solution than with a conventional one, which suggests an increase in mesothelial cell mass or mesothelial turnover. Many studies have shown this phenomenon. Let me see whether I can continue. There is still something.
Yeah, it's moving. It's moving. Just a click on it. Yes.
Yeah. Okay, so this is just to show you the CA125 data from one of the studies that have been done about this. It's a randomized controlled trial with a follow-up of 6 months. The green bars is the biocompatible solution, and the yellow brownish one is the conventional one. And you see that there's no difference in the beginning, but after 6 months it's significantly higher over here. Let's move then to peritoneal transport. Studies all small solute transport and ultrafiltration vary a bit. A number of studies showed no difference with conventional solutions or an increase, and the same is true for ultrafiltration, which a number of studies showed no difference, but also decreases have been found, especially in the studies where an increase in solute transport was found. And an example of this is given over here. This is a study from our colleague university in Amsterdam about the incident PD patients who started PD either with a biocompatible solution or with a standard conventional solution. And it was a study with a follow-up of 1 year, and patients were randomized for one of the two solutions, and after 6 months they switched to the other one. So that's the crossover point. And you see that the conventional, that's the NEP patients, had a higher D over P creatinine than the ones on the standard solution. And after switch, you also see that it increased in the ones who were switched from standard to NEP. The interesting thing is that they also looked at fascial endothelial growth factor in peritoneal effluent, and that really shows the same picture. So higher in the NEP patients and lower in the ones on the standard solution. And again, a switch over here after half a year, and you see that it increased over there and it decreased in the NEP patients. So, well, half a year is too short to get already structural damage. So it means that it's a functional difference, probably explained by the better preservation of mesothelial cells that are now able to produce more fascial endothelial growth factor. The ultrafiltration effect showed what you would expect, more or less the NEP patients. When patients were switched from standard solution to NEP, their ultrafiltration decreased, which is in line, of course, with the increased D over P of creatinine. So functional changes in peritoneal transport reported by some studies. What about advanced glycosylation end products in the circulation? I think you have to realize that glucose degradation products are low molecular weight solutes, and they are absorbed during a dialysis as well. These GDPs accelerate the formation of H's from glucose and proteins in the body. So mixing glucose and proteins together leads at the end to the formation of advanced glycosylation end products, but that process is accelerated by GDPs. And therefore you could think that when you treat patients with a biocompatible dialysis solution, that might inhibit this phenomenon. And I'll show you an example that a few clinical studies indeed reported lower serum concentrations of some advanced glycosylation end products, although the differences are rather small. And you see that here in this study from Germany, where they looked at carboxymethyl lysine in peritoneal plasma during a biocompatible solution and a conventional solution. And each line is an individual patient, and you see that most lines go up over here, the thick line is the mean value. It's not the case for all of the patients, but the difference is statistically significant, but rather small. So in fact, here it's 1.2520, and here it's something like 1.25. So really small differences. But it's interesting that indeed you can find these differences. Which then brings me to residual renal function. I know there is a Cochrane review that says that there's better preservation of residual renal function on biocompatible PD solutions, but there's no pathophysiological background for that. And also not all studies are of a very good quality. I selected 2 randomized controlled trials that I want to share with you. The first one, this is the first one. This is from the United Kingdom. 93 patients, so not extremely large, randomized for either biocompatible or standard solution, follow-up of 1 year, but you see residual renal function declines in both groups without a difference. And the same is true when you look at urine production, urine volume also that shows a decline without an evident difference. This slide is from a larger study, a randomized controlled trial from Australia and New Zealand in a much larger number of patients, 167 incidence patients, the BALANCE study. And what was found in this study was that there was no difference in the decline of residual renal function between the 2 solutions, only some difference in the time to anuria, which you see here in this slide. Indeed, the patients on biocompatible solution kept urine production for a longer time than the ones on the conventional solution. So by and large, I think that the effects on the residual renal function are really non-existent, or if they exist, are not very large. Which then brings me to the incidence of peritonitis. Again, the BALANCE study, which is I think the best one on this. In the BALANCE study, no effect was present on the incidence of peritonitis, but it took a longer time before the first episode occurred, and you see that over here. Blue is BALANCE, and the red line is the conventional solution. Those were let's say the short-term effects. So let's switch then to long-term effect of biocompatible solutions. And I want to discuss with you some studies on the morphology, again on effluent CA125, on peritoneal transport, and on patient survival. First of all, morphology studies with biocompatible solutions. I think 5 studies have now been published. Only the study of Dr. Schaefer that you heard yesterday was in children, pediatric patients. All the others were in adult patients. And a number of studies, the first one, the second one, and the last one are from Japan, and this middle study is from Spain. But in fact, all studies found a better preservation of mesothelial integrity and a reduction of peritoneal fibrosis. The fasciculopathy and the deposition of advanced glycosylation end products in the peritoneal tissues were less but were still present. And that's probably because there's still glucose in those solutions. And the vascular density, so the number of peritoneal microvessels, was either unchanged or increased, as was discussed with you yesterday by Professor Schaefer, a finding that was done in the pediatric population. So I don't know how. So that has not been described in the adult patients. What about CA125? Well, as I show you in the short-term studies, in the beginning, the biocompatible solution is associated with a higher value of CA125, but it decreases in time, and there is no difference in the decrease between the conventional solution and the biocompatible solution. So in the beginning they are higher, but they both decrease in time, although at the end, after 5 years, it's still higher in the conventional solution. So it means that biocompatible solutions give better preservation of mesothelial cell mass, but it decreases with time. And then they are the data on peritoneal transport over here. 3 studies have now been published. The first one was the balance study. I already talked with you about that. A large randomized controlled trial, but the problem is that the follow-up was only 2 years, so that's not really long term. And then recently, 2018, the global fluid study was published. It's a multi-center, multinational, prospective observational cohort study. But the problem is that they only looked at small solute transport, so D/P creatinine. Follow-up was long, maximum value was 7 years. And then the last study is the AMC study from my hospital, which will be published shortly in the international reports. That is a single center study, prospective longitudinal follow-up, looking at solute and fluid transport both. So in fact, this is the only study looking at long-term fluid transport. I'll show you some of the data of the various studies. This is from the balance study. Here on the left, you see the time course of D/P creatinine, and here on the biocompatible solution, and here on the standard solution, the conventional solution. And as has been shown a lot of time, D/P creatinine increases with the duration of PD. Also, but this is not the case with balance, with the biocompatible solution. There it is rather stable. And what you can see also here is that the initial value on balance is higher than over there, than on the conventional solution, which is in agreement with data from other studies, from the short-term study that I showed you. So this is the time course of D/P creatinine, and this one is ultrafiltration. Well, again, biocompatible and conventional, a small decrease during those 2 years in ultrafiltration, and no effect on the biocompatible solution. And also here, when you look closely, you'll see that the starting point here is a bit lower than over there. Also confirming the results of the short-term study. This is D/P creatinine from the global fluid study. Now the conventional solution is here on the left, and the biocompatible solutions are on the right, the overpediatric. So you see indeed an increase again, and you see that on the biocompatible solution, this was not found. No increase, or rather a kind of stabilization. This is from the AMC study. The mass transfer area coefficient of creatinine is what we calculated. A span number here should be replaced by year number. This is what happens with the conventional solution. Not very much until the third year, and then you have a breaking point, and after that it increases. So just as what has been found in other studies, and this is the biocompatible solution. Really not very much happens, a very slight decrease only. And this is ultrafiltration after 4 hours, measured with a 3.86% glucose solution. And you see that on the conventional solution, there after 3 years, there's a marked decrease in ultrafiltration, which is absent in the biocompatible solution. Only at the end some decrease is present here. And then if you look at small pore fluid transport and free water transport, and I discussed with you yesterday what that meant, free water transport. You see that on the conventional solution, there was a marked decrease in small pore solute fluid transport, and also some decrease, and also a decrease in free water transport. And on the biocompatible solution, there are still some decreases with duration of PD. So that still decreases, which then brings me to data on survival, on patient survival on biocompatible solutions. 3 studies. The first 2 studies were hampered by the presence of a selection bias. So it was absolutely unclear how patients were selected for one of the 2 treatments. So the results can really not be interpreted. There is one randomized controlled trial in a large number of patients from the United Kingdom, 267 patients. And I'll show you the results. Absolutely no difference in survival, which is also something that is not really a surprise, I think, because there are lots of reasons why patients die, and the biocompatibility of the solution is probably of rather limited importance here. So I'll show you a number of things on biocompatible solutions. So things to remember on those are that there's less inflow pain, a higher CA125, but still a decrease in time, better preservation of peritoneal morphology, initially higher small solute transport rates and lower ultrafiltration, but less effects of PD duration on their time course, no effect on residual GFR, but maybe on urine production. Results of peritonitis are equivocal, no effect on patient survival. And when you ask, are they superior to conventional solution, I think the answer is evidently yes. I thank you for your attention.
Thank you, Professor Kredit. We have some questions here. Number one is asking about the, so what do you think about the implication of increasing CA125 with the biocompatible solutions?
I think the fact that it's that you find higher values suggests better function of mesothelial cells or a higher mesothelial or a larger mesothelial cell mass. And that is supported also, for instance, by the finding that vascular endothelial growth factor in peritoneal effluent is higher on biocompatible solutions than on the conventional ones. So also that suggests better mesothelial function. You know that conventional solutions are very bad for mesothelial cells. It impairs their function. So there's less impairment of mesothelial function. That's what it says. And the decrease that you have in time shows that even though there's less impairment, at the end, some impairment occurs.
Okay, good. There is another question here about Kanan. Like he's asking about how many years maximum patient can do on peritoneal dialysis. Maybe that's the related question regarding either on biocompatible solutions or conventional solutions.
I think, well, I think that look, most patients drop out after some years, mainly due to transplantation or because they die, and that is not different with hemodialysis. When you look at the peritoneal membrane, the damage that is done to the peritoneal membrane with conventional solutions is much bigger than with biocompatible solutions. So I expect that in those patients who don't have a transplant or have a failed transplant, so remain on peritoneal dialysis for a long time, that membrane changes to take them off PD are more limited on biocompatible solutions than on the conventional ones. And what really is a problem, reason to take patients off is ultrafiltration failure. And I've shown you that that occurs less often with the biocompatible solution than with the conventional solution.
Okay, thank you, Professor, for this elegant talk and very illustrated information. I will give the mic now to my colleague, panelist, Dr. Al-Anud Sami. So the mic
Dr. Abdelhadi Talhi, if Dr. Prof. Martin, share your screen, and Dr. Abdelhadi, if you can introduce the speaker.
Thank you very much, Ali. I am Dr. Abdelhadi Talhi. It is my pleasure to introduce, for those who didn't attend yesterday, Dr. Martin Wilkie. He is a consultant, renal physician, and honorary professor at Sheffield Teaching Hospital NHS Foundation. Also, he is actively involved in clinical research and is the chief investigator of the NIHR UK peritoneal dialysis catheter. Welcome, Prof. Martin. You can start your talk.
Thank you very much. I hope you can all hear me. I'm just going on to the slideshow now.
Yes.
So great. So it's a great honor to be here, and thank you for having me back. I'm so impressed by the number of participants you have in this wonderful meeting. So my duty for the next half hour is to give you a clinical literature review on peritoneal dialysis, and I've just itemized the themes I'm going to cover very quickly going forward. So you'll see where you are in the talk as we progress. So starting at the top, we're really interested in the growth of renal replacement therapy, and this is from the US RDS International chapter, well worth looking at. And you can see that Saudi Arabia has been selected as a country where there is considerable ongoing growth in need for renal replacement therapy, and that presents a challenge for the years going forwards, responding to that growth. Of course, it's really important to be aware that there are other developments in the renal world which are really key, and the SGLT2 inhibitors are going to make a big impact on outcomes for people with type 2 diabetes, for example. So there are other influences which will impact on that, but we have to be aware that it's likely that over the coming years that more people will need renal replacement therapy. I've put here from the US RDS chapter Saudi Arabia and the transplantation rate, and you can see that Saudi Arabia has got a really active transplant program and share that information internationally so that can be seen, and you can see in a very prominent position here internationally. But we don't have similar data around dialysis or home dialysis, so I don't have that to share with you. On this slide, I'm showing you just on the left-hand panel a variation in the use of peritoneal dialysis across a range of countries. I mentioned this yesterday when I was talking to you, and you can see the huge variation with some countries really making a strong use of peritoneal dialysis, such as Hong Kong, Mexico, New Zealand, Australia. And on the right-hand panel, which I have shown you from a paper published a few years ago now, but you can see countries with growth, and in particular Thailand, I mentioned yesterday, have managed to increase their use of PD in order to solve their renal replacement therapy problem. So clearly, PD is part of the solution. I showed you this slide yesterday. The big question is, why is it used so little when it has such potential? And in the United States, where they've changed the payment mechanism in the last few years, this paper published recently in JASN is really relevant, actually published last year, and it shows the growth in both incident and prevalent PD during that period. So incident going from 9.4% to 12.6% and prevalent 12.1 to 16. So big change, actually a doubling in the numbers of people in PD over that period of time. So it is possible for a country to change its approach and therefore grow PD. This slide is a composite of a number of different pieces of work, but it shows you that key question which was raised earlier around barriers and solutions. And I think it's well worth studying this slide. You can see the kind of barriers that people present, frailty, social isolation. Edwina Brown talked about the use of assisted services to help. Modality choice, the importance of patient and medical education programs, the need for high quality catheter insertion, responding to late presenters, preventing technique failure by having high quality care, and also having the right financial systems. So what are the outcomes that matter to people on peritoneal dialysis? This comes from the SONG work, Standardized Outcome in Nephrology, which is a really systematized approach to understand what matters to patients and carers. And you can see the domains which really matter here in the dark blue: infection, cardiovascular disease, mortality, technique survival, and life participation. These are the things that matter to patients and healthcare professionals around their PD patients. So what about survival? We had that question just in the last during the last talk. Which modality is better for survival? And I'll tell you what the message is. The real message is the thing that influences survival in dialysis is the comorbidity of the individual that you're treating rather than the modality. So that's the key message, the comorbidity of the individual. We have registry data from multiple registries across the world showing advantage for PD, but remember that is not randomized, so there are systematic biases to registry data. And here you can see, looking at the US RDS, the early advantage for PD, and after some time it tends to be lost. Sorry, this shows better survival from, this actually shows better survival for PD, recently. I got confused, for PD than HD in the US RDS, but in the European registry, you can see in the early period a distinct advantage in terms of survival. And Mark Marshall recently did a meta-analysis of over 800 patients from 18 countries looking at the various registries and really demonstrated this early period of advantage for PD and the impact of that. Of course, we don't have many randomized controlled trials in this area. In fact, only two, the Nekazad study, which came from the Netherlands at the end of the 1990s, and the China Q study. So only two studies, not really enough for a meta-analysis, but it gives you the indication that supports what we know already, that initiating people on PD certainly is not disadvantageous. Okay, so the next question I wanted to cover was technique survival. I alluded to this yesterday. This is from the ANS data paper in CJS in 2017. And the key causes, and I always think, what's the issue here? The issue is going to be infection and access. These are the things we need to deal with at the beginning, right? And then there are other things like clearance and other matters, but infection and access we need to deal with. And when it comes to infection, I'll remind you about the ISPD guideline, very important. But these days now we have the PDOP study to inform us. And this just shows the importance of multinational cohort studies looking at these questions to give us more information. And you can see the countries involved in this recent publication in AJKD this year, the 6 countries involved, the different organisms, very important to get that sort of information. And we can see how these different countries fare. And in particular, the wake-up call for the United Kingdom, our infection rates are similar to those in Thailand and distinctly worse in the US and Canada. No room for complacency for us in the UK. And this kind of information is very important to focus a country on how to improve care in their own particular domain. So hence the importance of these kind of studies. Here's a study from the ANS data registry. I think that's an excellent registry, and I'd encourage you guys to think about developing such a registry in Saudi Arabia. And they're just looking at culture-negative peritonitis and how that does. And I'm just using this as an example of the value of these registries. You can see the outcome for fungi, so much worse than, for example, Pseudomonas, worse than for culture-negative. Which antibiotics are better, but if you use the aminoglycosides, it seem to be more advantageous than if you didn't, for example. So you get some trends from these kind of information, these kind of data. And here's a review recently published in PDI looking at the pharmacokinetics of vancomycin in PD. Really important for us to understand how to use antibiotics effectively, to make sure that when we use them, we're giving adequate amounts, taking account of dialytic and renal clearance and these kind of issues. And my message to you is if we use vancomycin, it's important to measure the levels to make sure we're giving enough. Now, what about preventing peritonitis? Well, there's a randomized controlled study published in PDI earlier this year, multi-center study on retraining, and unfortunately, it didn't show any impact. So clearly, we need to go further and learn better how to respond to preventing peritonitis. Patients have a whole range of different learning styles. This is from the ISPD guideline on training for peritoneal dialysis. You can see the different types of learning styles. We've got visual, oral, kinesthetic, and read-write. So our teaching has got to respond to that. And the Australian group have set up a study called Teach PD, which aims to understand best how to teach around peritoneal dialysis, and that's going to be important going forward. Now, moving to access, which I mentioned is the other key cause of technique failure. There's the ISPD guideline, which I draw your attention to, again, free to download. And I talked to you about the North American PD catheter registry, which in this paper recently published looks at laparoscopic insertion. And if you remember from yesterday, about 24% of people had some sort of problem with their catheter one way or another. And what was the impact of that? But before you get there, on this slide, I'm just showing you the kind of information they collect in that really complex registry: catheter type, insertion point, method of entering the abdomen, other techniques. So really quite complex data. And it's really interesting that if we look at those who never started PD, that catheter flow is responsible for about 40% of that problem. People who had their PD interrupted, catheter flow is responsible for 35%. So clearly this is an issue that we really need to understand better. And I invite you to the Congress that we're going to hold early next year, because we're going to present the data of the UK catheter study, a cohort study in 34 centres at that meeting. So what about glucose polymer? Ray Credit talked about ultrafiltration, very important. The role of icodextrin over the years has really demonstrated benefit, and this is from the systematic review using icodextrin, and it shows reduced uncontrolled fluid overload episodes. And the Australian registry is able to collect the use of icodextrin in that country and the associated factors. And in particular, you can see icodextrin use increasing during that period in Australia. And the kind of indications, the associations more likely to be used, for example, in diabetic patients, real value there. In those who are on APD, for example. So it's important to see the associations with its use. We talked yesterday about goal-directed peritoneal dialysis, which is the concept around trying to tailor the treatment to the individual, considering the different components of it. And this is published as a guideline in the ISPD. And in that guideline, you'll see this complex table which looks at the different aspects to consider and the individual characteristics. So the prescription of peritoneal dialysis requires a nuanced approach, and that's the point that I want to make for you here. Thinking about volume, there's a volume guideline there too, and what I want to show you is this meta-analysis of bioelectrical impedance across dialysis, and in peritoneal dialysis, a useful technique, particularly following an individual patient longitudinally, but so far no randomized controlled trial evidence to show impact on hard outcomes. More to learn there, but certainly a useful technique in the management of people on peritoneal dialysis. The PDOC studies really helped us with understanding the different prescriptions across those contributing countries. And here you can see the use of APD versus CAPD. So for example, in Thailand, very little APD. In the US, APD is used predominantly, and a variation between the contributing countries. And then if we look at the use of glucose, really interesting to see this in the US, really quite a considerable use of those extra strong, those 3.86% bags, whereas, for example, in the UK, not used at all. So you can see variations in practice patterns, which we are going to then associate with outcomes, and very interesting to study and to learn. And then as I come towards the last part of my talk, I want to mention a little bit about digital health, which we've all become very familiar with over the last few months of this pandemic. And indeed, this excellent conference indicates the wonderful advantages that there are of the virtual platform. And this paper recently published in AJKD just summarizes the challenges and the benefits, potential benefits of telenephrology. And of course, over large geographical areas, it allows us to keep in touch with our patients and monitor their progress. During the pandemic, our clinics turned almost ubiquitously to being remote, and we've learned how to do that reasonably well. But there are things we need to be aware of. We need to understand, for example, that there are those who have barriers to digital use, and we need to enable so that they can use it well. And we also need to be understanding of where its strengths lie and where its weaknesses lie. So we do need to have good evidence of how to use digital nephrology best of all. There's a systematic review published this year in PDI looking at e-health solutions in peritoneal dialysis. And to cut to the chase, so far, no randomized controlled trials that have given us robust evidence. There's a Cochrane review in this area as well, looking at digital nephrology. I'm not going to show you a slide on that, but just to tell you, it showed evidence around salt restriction and volume management as far as I recollect, but not much else. So there's a lot of work to be done to build evidence in the area of the impact of digital health. This is a study from Colombia that have done quite a lot of work in this area, and this is a longitudinal cohort study, and they did some propensity score modeling and Markov modeling and showed a potential financial and benefit and impact on infection. More work to be done here, but I encourage everyone to participate in research in this area. The other thing that we mustn't forget is the qualitative research. I think this is really important. We like numbers, but we also like stories. And this is from Rachel Walker's work in New Zealand, talking to clinicians about their experience of remote patient monitoring with peritoneal dialysis. Clearly very positive messages here: enhancing patient-focused care, promoting and maintaining peritoneal dialysis, enabling data-driven decisions, and establishing boundaries for use. I think real value there. During the COVID pandemic, again, of course, remote monitoring has really come into its own. And here's a paper published earlier in Peritoneal Dialysis International from Northern Italy, Claudio Ronco and his team. And he just talks about the different pathways, and I'm sure you will have very similar experiences with your pathways for maintaining and managing people who are potentially infected with COVID-19, and indeed keeping those who are not have not been exposed to it as safe as possible, maintaining people at home while monitoring them remotely. And I like to just present a case presented to us during the height of the pandemic, a person presenting with advanced chronic kidney disease, severe hypertension, presenting late, requires to hemodialyze using a femoral catheter for the first dialysis or two. But very quickly, it was clear that remaining in hospital was a risk. Peritoneal dialysis catheter placed, the patient started acutely on PD, and using remote monitoring gave us confidence as they went home quickly for us to see that the cycles were working well and to bring that blood pressure under control. So a real advantage for it to be able to use that technique in patients of this sort. And I'm just coming towards the end of my talk now. I'm showing you data from the UK Renal Registry on the COVID-19 surveillance in the renal population. I'm not showing you the numbers infected, I'm showing you the mortality here. And sadly, very sadly, to tell you that among the in-center hemodialysis population up to this point, 23rd September, 2.6 of the population, 2.6% had died of COVID, but in the home therapies population, it's only 1.1%. So clearly we're all very concerned about how to minimize this risk, but like many other reports, you can see distinct advantages of trying to keep people independent of the hospital and in the community where possible to minimize the risk of transmission. My final slide is to talk about registries, and I think there's a real advantage in renal registries, and it's really helped us through this pandemic to get clear data about what's going on and across the world to understand the presentation of renal disease and its management. And this is a paper published about 5 years ago now, looking at the different renal registries, and you can see how they're distributed across the world. And I think this is certainly an important thing to develop across the world, because it enables the sharing of high quality data around patient outcomes. So to wrap up, I cantered through that talk rather quickly, quite a lot of information there, but I was just drawing your attention to a number of themes that I thought were important. Peritoneal dialysis, I believe, provides opportunities for high quality community-based patient care. To achieve this, it's really important to understand patient and clinician priorities and to respond to them. We require collaborative research, such as the PDOPS data, which I showed you about, longitudinal collaborative research, large randomized controlled trials, very important. Quality improvement methodologies need to be informed by registries, and clinical guidelines are very important in underpinning those. We also need to take steps to ensure that all groups within the population have got access to home therapies, irrespective of socioeconomic or racial background, and that's relevant across the world, including in the UK. The relative advantage of home therapies has been highlighted during the COVID pandemic, and patients who are managed at home require to be well supported, and indeed remote monitoring using digital health helps here. So thank you very much for your attention, and I'm very happy to answer any questions that you might have.
Thank you very much, Prof. Martin. We have a few questions. First question. He said you have nicely mentioned that one of the most common barrier to PD is PD access. Nowadays, there are several centers in Saudi Arabia use the innovated 3 cuffs Saudi PD catheter with low entry technique, which has 0 rate of migration and less peritonitis rate and other benefits. Are we going to see this catheter anytime soon in the ISPD recommendations?
Well, the ISPD guideline reviewed evidence, as you know, and it's all a question of the level of evidence. Was there randomized controlled trials? There were, how the sort of the extent of them, but certainly people are aware of this catheter and it's gaining prominence through the world. And you guys have been advocating it, and people are becoming more aware about it. So I expect it will be in the guidelines coming soon. But I would encourage you to to build the evidence. That's very, very important, as you have been doing. So good work, and really, really excellent work to be encouraged. Thank you very much for that.
The next question, they said, why during transplantation patients still receive dialysis? It is have relation between transplantation and dialysis? I don't know, but this is question by one of the audience.
Sorry, could you repeat the question for me again? I didn't quite.
What's written here, why during transplantation patients still receive dialysis? It is have relation between transplantation and dialysis?
So what's the relationship between transplantation and dialysis? And I suppose there are a number of relationships. First of all, if you can transplant people preemptively, that's really good news. But of course, many circumstances it's not possible to do so. Of course, in some cases, sadly, the transplant will eventually stop working, and then one needs to have a dialysis modality available subsequently. And there is evidence, again, that starting on PD is a good thing to do post-transplant failure. And then finally, the question is this approach of trying to keep people in the community, cared for in the community. Transplantation is an excellent way of doing so. Home dialysis is another, and indeed the United States has now developed a target of 80% of prevalent patients being either transplanted or on a home dialysis modality. So these are very closely linked to each other in their interaction, and there's a final way that they're linked to each other. In countries that have very low transplantation, one has to remember that the comorbidity of people on dialysis tends to be lower than in those countries that use transplantation to its full potential. So that affects what looks like the outcome of people on dialysis. If you take all your very well people and transplant them, then you're left with the frailer and more poorly people on dialysis, and of course the outcomes will be less good, understandably. Does that help?
Yes, thank you very much. What is the mortality rate between PD and hemodialysis patient those affected with COVID-19?
Well, so it's difficult to know. And the reason why is we don't really have enough studies. And some of the studies have been slightly confused, and I'll explain why. Because people attending the dialysis unit 3 times a week, if they become unwell, are quickly identified and hospitalized, yeah? Whereas those who are dialyzing at home and in the community, the approach to identification is different. So they're likely to become much more poorly before they're recognized by the clinical teams, if you see what I mean. So there's no clear answer on that. But the top line data that I showed you is that the risk of mortality during the COVID pandemic is about 1/2 to 1/3 lower for those dialyzing in the community than those dialyzing at centers for the 2 or 3 registries that I've seen at least.
Okay, thank you very much. Very nice talk. Let's go now to have next speaker, and with the panelist, Dr. Al-Anoud, if possible.
Dr. Al-Anoud, you can introduce.
Yes, I'm here. Yes.
Yes.
Sure. Masā al-khair jamī'an. Good evening, everyone. It gives me a great pleasure this evening to introduce one of the world figure of in the field of pediatric nephrology, Professor Brad Wardy. He is a professor of pediatrics at University of Missouri, Kansas City School of Medicine, and Director Division of Nephrology, Dialysis, and Transplantations at Children's Mercy, Kansas City. Apart from being a well-known figure and a great clinician, he's also internationally recognized researcher with more than 500 publications. Professor Brad is actually a strong advocate for children with CKD, and he's a strong believer in the role of family and patient's perspective in providing the best care. And that's actually led to the great initiative that is the center of his talk today, which is the SCOPE Dialysis Collaborative. In addition to that, he's the senior editor of one of the important books in the field of pediatric nephrology, one of the great books that everybody, I'm sure, has read and enjoyed, which is the Pediatric Dialysis. Without further ado, I'd like to hand the mic to Professor Brad.
Well, thank you very much for that very nice introduction. Let me share my screen. So it's really a pleasure being able to speak to all of you today. It's 9 o'clock in the morning where I'm at in Kansas City, Missouri, which is about 7,300 miles away from you. So again, the great benefit of technology to allow us to all share some thoughts together today. What I'm going to do is talk about quality improvement, as Martin just mentioned to you how important that is. And I'm going to do so by speaking about a collaborative called the SCOPE Collaborative, Standardizing Care to Improve Outcomes in Pediatric ESRD. And I think some of the messages that I share with you will clearly apply to the pediatric patient, but I believe they'll also can apply to adult individuals who are receiving PD as well. So for those of you who are not pediatric providers, I want to give you some background information about pediatric dialysis. This is data from the USRDS, the United States Renal Data System, looking at the initial renal replacement therapy modality for children between 1996 and 2016. You can see the orange represents transplant, the yellow peritoneal dialysis, and the blue hemodialysis. So if we look at this data, you'll see that the majority of children less than 9 years of age do in fact receive PD as their initial renal replacement therapy modality. Now, many of our children are children like this, children with solitary kidney disorder and otherwise actually are quite well. Here you can see a child with the PD catheter in, as well as the gastrostomy button, which is present in many of our young children on dialysis. But then other children are much more complex, such as this young child here. You can see the PD catheters on the chest wall because this child also has a colostomy, and we separate the PD catheter from the colostomy to decrease the risk of contamination and potential peritonitis. And of course, unique to the pediatric population is the fact that all of our patients have parents who are trained to conduct a PD. In the US, the vast majority of PD is conducted at night on APD, and the parents undergo a 5 to 7 day education period so they can conduct that home dialysis. Now, what's most important to patients and caregivers who are on PD? This is adult data from 126 people, 81 PD patients, 45 caregivers from 9 clinics, 3 different countries, asking them what's the most important outcomes to you in this nominal technique. And you could see that was most important to them was infection prevention, followed by mortality issues, fatigue, and flexibility with time. And interestingly, if you look at the 56 different outcomes that these adults responded to, you can see that dialysate solute clearance, K2V, is not very important to the patients themselves, in contrast to PD infection or the prevention of infection, which was most important to them. Much the same can be seen in the pediatric population. This is an additional and a similar approach taken looking at children and parents with CKD and on dialysis, looking what's most important to them. And once again, infection prevention is critically important. Now, why is it important? This is data from the International Pediatric Peritoneal Dialysis Network, or the IPPN, looking at reasons for PD discontinuation other than transplantation, death, or loss to follow-up. And you'll note that infection is, again, the most common cause that patients have to discontinue PD. But in addition to infection directly, you can see ultrafiltration failure and adhesions represent another 31% of the causes for PD discontinuation. And as we all know, ultrafiltration failure and adhesions is most commonly secondary to infection. So nearly 2/3 of children who have to discontinue PD do so for reasons of infection. And then this is data on the leading causes of death from the United States Renal Data System and the CDC. So if we look at the general pediatric and young adult population, you can see there's no evidence of infection being a primary cause of mortality. But infection is the number 2 cause of mortality for children on hemodialysis, the number 2 cause for children on PD, and the #1 cause for children with transplant in the US. So infection prevention is a key issue that we have to address in the pediatric ESRD population. So in 2012, we published this updated guidelines under the auspices of the ISPD on guidelines for the prevention and treatment of catheter-related infections and peritonitis, and these are still active today, and ideally we'll be putting together some new guidelines in the very near future. But this was an international group that put together these guidelines, which I think lent itself to improvement in the care of children on PD. But we recognize that there is still more to be done, more to do to decrease the risk of PD infections in our patients. And so it was for that reason that we established the SCOPE Collaborative, which is truly a quality transformation collaborative, utilizing quality transformation methodology under the umbrella of the Children's Hospital Association in the United States. So the hypothesis was that if we can provide more standardized care across all participating centers, we will indeed improve the outcomes of the children cared for in these centers. And so our goal was to monitor adherence with standardized practices in all the participating sites, and then utilize quality improvement methodology with small tests of change to increase implementation of these practices across all of the sites participating in SCOPE. This is a slide of the US, as you can see, and each star represents another pediatric center that is participating in this SCOPE Collaborative. We started with 13 centers. We've now grown to 52 centers across the country. And this slide, I think, which is very informative. Here we're looking at the catchment area. Where do these patients go? What centers do they go to for their care? So each red dot there represents another SCOPE center, and you can see that we cover virtually the entire United States. So the SCOPE Collaborative, which started again with only 13 centers, because of its productivity and because of the important information shared from it, has grown now to be truly a national collaborative. So the goals of SCOPE is to increase implementation of standardized PD catheter practices, focusing on the PD catheter insertion, patient and caregiver training, and then the follow-up care of all these patients, with the goal is to decrease the rate of peritonitis and then exit site and tunnel infections as well. So what we've done is utilize the information in the literature and again, expert opinion to design 3 catheter care bundles. So this is the first catheter care bundle, the insertion bundle. So within this bundle, the key elements are as follows. Intraoperatively, the catheter exit site should be oriented in a lateral or downward position. A first-generation cephalosporin should be given and should be given prior to the surgical incision for the catheter placement, and no suture should be used at the exit site. In the postoperative period, a catheter is immobilized, no dressing changes in the first 7 days, and then it's done in a sterile manner every week, just once a week, until that exit site is healed, and then ideally no catheter use for 14 days following catheter implantation. And when we audit this bundle, one has to be addressing each one of these elements to be seen as being adherent to the bundle. Now, this is the second bundle, the patient and caregiver training bundle. So the training is performed by a qualified nurse on a 1-to-1 ratio with that patient and family. For each child, there's a primary provider and an alternate provider. There are teaching aids used. There are protocols based upon the ISPD guidelines. Protocols are used for aseptic technique, the WHO hand hygiene recommendations, and exit site care. At the end of training, there's a post-training concept test and a demonstration test. And then ideally, a home visit should occur prior to that child going home on dialysis. And then finally, the catheter exit site follow-up bundle. So the visit should be occurring on a monthly basis. Every month when that child is seen, the exit site should be scored by the dialysis nurse utilizing the IPPN scoring tool. And that at every monthly visit, there should be a review of hand hygiene, exit site care, and aseptic technique. Every 6 months, there's a repeat demonstration test and concept test. Retraining should be conducted after every peritonitis episode, and then prophylactics should be used if there's touch contamination or a break-in technique. So these are the 3 care bundles, again, based on the literature and best opinion. And then the goal is to standardize the approach by utilizing these through all the participating sites. Now, when we looked at the collaborative, we said, well, let's enroll all patients less than 21 years of age at a participating site. We collect the demographics of those patients in enrollment. There's monthly reporting of compliance. Remember, it's all or none. All the elements are being carried out, or again, the compliance is not there. There's monthly reporting of infection events, and we ask all the participating sites to share with us their infection data prior to entering the collaborative so that we can see the impact of, again, following these standardized practices. One other thing that I wanted to highlight for you is that the data collected by this collaborative is totally transparent. We all see each other's data so that those individuals who are doing poorly can get information from those sites that are doing well to hopefully improve the care that they are providing. So for instance, this is a slide looking at the compliance with the follow-up care bundle. So you can see some of the sites, and the names are all here. Some of the sites had very poor compliance early on, somewhere in the 10 to 15% range, whereas others were in the 95 to 100% range. But complete transparency as we work together to improve the care of children on PD. So to date, we've had over 2,200 enrollments, 1,800 terminations, some 1,500 new catheter insertions, almost 1,200 training sessions, 29,000 follow-up forms. We have information on almost 1,600 infections, nearly 1,200 episodes of peritonitis, and 400 episodes of an exit site or tunnel infection. So here we're looking over the first 3 years of the collaborative, and we're looking at bundle compliance. So this is the monthly % compliance by the center. And again, this is monthlies here, the dates. The blue lines represent the PD catheter insertion bundle, the orange, the training bundle, and the green, the follow-up bundle. And you could see that the lines are quite erratic because there are significant changes that occur on a month-to-month basis. But here you can see the green line, a progressive improvement in the compliance of the follow-up care bundle, starting at around 10%, then ending up here at over 90%. We also look at the different elements of the bundle. So again, here we're looking at the follow-up bundle. You can see the various elements here: exit site scoring, hand washing reviewed, aseptic technique reviewed, and so on. And you'll see that most of the elements were able to be incorporated into care of these centers very rapidly. The one that lagged behind was carrying out the demonstration and concept test. Seems to be harder to incorporate that into the regular care that these children are being provided. So if we look again over those first 3 years, what we found that it took about 2 years, when we look at that follow-up care bundle, about 2 years until we reached 80% compliance, where the vast majority of centers were in fact adherent with the follow-up care bundle. Now, why was that important? Well, here we're looking at the mean monthly peritonitis rates. This is pre-collaborative activity. This is post-collaborative. And this green line represents the follow-up care bundle compliance. And what you can see is as the compliance rate increased, we saw a progressive decrease in the variability of the peritonitis rates and actually an overall decrease in the rate. And in fact, when we compared the pre-launch peritonitis rate to the post-launch rate, looking at the annualized peritonitis rate, you can see it went from 0.63 infections per patient year to 0.42 infections per patient year, statistically significant changes. And in fact, when we did a sensitivity analysis, we indeed found that it was a compliance rate of 80% in terms of that follow-up bundle that was associated with a significant fall in the peritonitis rate. So here we're looking at data now, not only through that first 3 years, but for 3 more years. So again, off to October of 2017. This is the rolling 12-month compliance rate. Once again, the red represents the insertion compliance, the blue, the training compliance, and the green, the follow-up compliance. So you can see that the follow-up compliance, even 3 years later, was sustained at somewhere between 80 and 90%. Here you can see we haven't achieved overall compliance at the same level, and I'll show you why in a moment for these 2 bundles. But despite that, you can see as we move off to, again, 2017, we continue to see a fall in the peritonitis rate with an increasing number of sites enrolled in SCOPE, where the infection rate has gone from an annualized rate of 0.44 infections per patient year, now down to 0.31 infections per patient year. Again, statistically significant improvement. Now, why is it that we're not achieving the optimal adherence with all the bundles? Well, here we're looking at the insertion bundle, and the biggest problem here is this one element here: no catheter use for 14 days. In many children who have a PD catheter placed, they do in fact require dialysis within that 2-week period of time, and that's the major obstacle to achieving the overall compliance with the bundle. But you can see all the other elements have very high compliance rates. And here we're looking at the overall training bundle. Again, one element lags behind, and that's the home visit, as you can see here. It's taken some time to achieve a visit in many of those centers, but all other elements, again, have been incorporated into the care of these children. And then, as I already mentioned to you, again, some lag in carrying out the demonstration and concept test in many of the sites, but all other elements have been achieved quite readily. So again, I think you can take a site that is not necessarily practicing all the standardized practices, and for the most part, they can incorporate them in relatively short order. So here I just wanted to show you data. Again, this is the most recent data through October of 2020 that demonstrate to you we've been able to sustain the very low peritonitis rate, despite the fact that the number of centers has grown from 13 centers to 52 centers. By utilizing these standardized practices, again, we can maintain a very low peritonitis rate in the children. Now, we've also looked at other issues, and not just at the central level. We've looked at the individual patient level, risk factors for peritonitis, and this is from a publication by Christine Sethna several years ago. You can see all the different variables we looked at. Certainly, touch contamination was one of the issues that was associated with an increased risk for peritonitis. But another important one was the orientation of the catheter exit site. And we now know that an upward orientation of that catheter exit site in children is definitely a significant risk factor for peritonitis in these kids. And so that's why in my center and in the vast majority of centers throughout the US, we utilize the swan neck catheter that has the preformed downgoing exit site for these kids. Now, we've also looked at the issues of when should you be starting peritonitis. And you remember that in the bundle, it suggests that one should not start peritonitis, ideally, should start peritoneal dialysis, ideally, for 14 days after PD catheter placement. So we looked at that and a number of other variables in terms of the risk for developing peritonitis in the first 60 days after PD catheter placement. And indeed, in the multivariable analysis, the only significant risk factor was early PD catheter use, or use within those first 14 days following PD catheter placement. Now, we've also used the SCOPE data to allow us to look at subsets of patients, and an important subset are these complex patients, the infants on PD. And we reviewed information on 156 infants, all of whom received a PD catheter at less than 1 year of age. When we looked at these children, you could see there were 65 episodes of peritonitis in 65 different children for an overall annualized rate of 0.76 over their first 1 year of peritoneal dialysis. Now, of interest, of those 65 episodes, 23 of those episodes occurred during the initial hospitalization, when these children, in fact, received their PD catheter. And during that initial hospitalization, you can see that the annualized rate of peritonitis was very high, of 1.73. And these patients were not utilizing standardized practices because they were actually all in the hospital at the time. The impact of the peritonitis can be seen here. So here we're dividing the individuals, those who did not experience peritonitis during that first year and those that did. So you can see that if we look at the population that experienced peritonitis, they had a significantly longer number of hospital days, again, during that initial hospitalization. Their initial survival rate during that initial hospitalization was significantly poorer than those who did not experience peritonitis. And even over the first year of PD, their survival rate was significantly poorer than those who were peritonitis free. So peritonitis in these young infants is associated with significant morbidity and mortality. And then, of course, we looked at potential risk factors for peritonitis in these children. And in a multivariable analysis, what we found is that the two independent risk factors were a nephrectomy prior to PD catheter placement, and importantly, a G-tube placement after the PD catheter was placed. And there are certainly recommendations in the ISPD guidelines as how to best approach G-tube placement in these children to hopefully decrease the frequency of peritonitis following that procedure. So I talked to you about morbidity, mortality. More than that, there's also a fiscal benefit to incorporating all of the standardized practices that we have done. When we look at the rates of peritonitis prior to centers entering the collaborative, we can then estimate how many infections we prevented, how many hospitalizations we prevented. And as you can see, we prevented, on estimation, almost 700 peritonitis infections and 402 hospitalizations at a cost savings of over $12 million in the United States. So again, preventing peritonitis in these kids decreases morbidity, decreases mortality, and has definite fiscal benefits. Now, in addition to sharing information in terms of the data and following standardized practices, by having this collaboration of centers, it also allows us to share with each other other techniques we can do to continue to help prevent peritonitis and other infections. So for instance, we use the glow germ, and in my center, the glow germ is a way to see how well people are actually washing their hands. And so at every clinic visit in my hospital, the families, the parents, and potentially the children are utilizing this glow germ after washing their hands to show us where sort of the deficits might be and how they can more optimally do hand hygiene. In some centers, we use video audits, both from at home or in the center, and we share video games with different families to, again, reduce that fatigue of following practices. And then we also use a simulator. You know, I think our staff continue to need more education to improve the care they provide. And this is a simulator for PD that was generated at Boston Children's Hospital, and it allows our staff to maintain and actually excel at their skills so they can provide the best education for the families. And then, of course, we're always looking at ways that we can further improve the PD practice in terms of infection prevention in our patients. And this is data looking at culture negative peritonitis, really unfortunately a common problem. So here we're looking at a number of different sites in the SCOPE Collaborative. The blue bars represent the total number of peritonitis episodes at the various sites. The green line represents the overall culture negative rate of these sites, and you can see it's too high, 26%. And the red dots represent the culture negative rate at the various sites. And you can see that it's quite variable. At these sites, it's over 60%. At these sites, it doesn't exist, and here somewhat in between. So quite variable in terms of the frequency of culture negative peritonitis. So we said, let's look at some of the factors that may impact this culture negative rate. And this is a paper that will soon be published in CJSON that reflects our experience. So what we did, as you can see here, we looked at our experience over, again, almost 6 years, some 1,100 children on PD, 1,300 catheters, 19,000 patient months, and over 600 peritonitis episodes. And we divided the centers in those who were low culture negative rates, or less than 20%, and the high culture negative rates were greater than 20%. And indeed, we found that there were some differences in terms of the exit site orientation, the number of cuffs on the catheter, and who performs the dialysis. But the most important thing that we found is that there was highly variable results in terms of the culture techniques. That despite the fact that the ISPD in both the adult guidelines and the pediatric guidelines give clear recommendations in terms of how PD fluid should be cultured, the results were very variable. And in fact, here you can see, here we're looking at the PD effluent culture process and looking at centrifugation, a very important component of culture. The red represents those centers that are non-compliant, the blue, those that are compliant, and you can see the variability in terms of the compliance with this one step in the culture technique. So we think that this variability has an important role in the variability of the culture negative rates across our centers. And we said, let's now move forward and put together a bundle, a culture bundle that will hopefully provide more uniform approach to the culturing of PD fluid and hopefully decrease the culture negative rate. And so I just want to share with you, this is the bundle that we're using. You can see, again, we recommend a 50 ml or greater sample of fluid be used and sent to the lab. The sample should be delivered to the lab in less than or equal to 6 hours after it's collected. Most importantly, the specimen should be centrifuged for culture. We have recommendations in terms of the agar plates and then the use of blood culture bottles. And so we will be following this as we audit the sites to see how well sites can actually comply with this culture bundle, and then look at the impact of this bundle on the outcome of culture negative peritonitis. So in summary, the SCOPE Collaborative is a national initiative designed to enhance infection prevention strategies in pediatric dialysis utilizing quality improvement methodology. Widespread participation has facilitated the identification of important risk factors for infection. The introduction of PD catheter care bundles has successfully resulted in a significant decrease in the peritonitis rate of participating centers. And then finally, while continuing to target infection prevention strategies in PD, SCOPE is now using similar methodology to decrease the frequency of HD catheter-related infections in children on chronic dialysis. So my last slide, this is our collaborative made up of nurses and physicians. We meet together every 6 months, at least prior to the pandemic. We meet together every 6 months. And I think that 6 month face-to-face interaction is so important to not only share and celebrate our results, but to share ideas and to learn from one another, all with the goal of improving the care for all these kids on dialysis. So I thank you for your attention.
All right, thank you very much, Prof. Barrett. I think we have room for a couple of questions. First question, I'll rephrase it. Compliance and adherence of small children is way better than adolescents for a reason related to self-esteem, body image. What can we do to improve adolescent adherence to peritoneal dialysis?
In the pediatric population? Or
in the pediatric population. How can we improve the adolescents' compliance to
the adolescents? Yes. Well,
yes.
You know, adolescents are clearly a challenge. I think we have to continue to try to educate these teenagers, the adolescents, about the importance of working together as a team. And as we all know, peritoneal dialysis is a team sport. There has to be a partnership between the patients, the families, and the healthcare providers. And when I see patients, especially teenagers, I say to them right from the very beginning that communication between us is critical to our success. And so I think we have to recognize that we have to see them as partners, and we have to listen to them. They have concerns. There's issues that they may not want to follow exactly as we recommend, and we have to ask them why, explain to them, or maybe we sort of alter what we recommend sometimes based upon the needs of the child. But I think we have to work together and understand that they're very insightful. They have likes and dislikes, and we have to recognize those and incorporate them into our thinking process and into our recommendations.
All right, the second question is, do you use fibrin glue for acute PD catheter insertion? If so, what is the success rate?
Yes, it's a great question. We do. This was something that was published many years ago by a Dr. Ernesto Sojo from Argentina, a good friend of mine. And so when we put in especially we're using a tank-off catheter for acute PD, we will use fibrin glue, at the peritoneum to try to decrease the risk of leakage. But of course, along with the fibrin glue for acute PD, we'll also make sure we use a low fill volume, something along the lines of 10 cc's per kilo. And with that combination of fibrin glue and a low fill volume, we do quite well in terms of preventing leakage in the acute setting.
All right, last question. It is, despite that we did not achieve in your study, that you did not achieve optimal adherence with insertion training care bundle, there was a significant drop in the rate of peritonitis. And one would think that the most important measures to prevent peritonitis is to take care of catheter insertions, meaning the two bundles, the training and
Sure.
catheter insertion. How would you
Sure.
explain this drop?
Well, I mean, I think the drop has occurred because remember, almost all the elements for both of those bundles were in fact carried out. The only elements that were not carried out was one, the home visit, and then number two, starting dialysis early on in those young children who need to start dialysis. So, you know, we don't know in particular what particular element is the key to lowering the rates. But I think the data would suggest to you that we do a very good job lowering the rates, even if we, again, don't conduct that home visit. So one has to take, you know, all those elements into consideration. And again, as I showed you, the vast majority of elements for both those bundles were in fact carried out, and the centers were in fact compliant with them.
All right, last question. Is peritoneal dialysis a contraindication in patients with suprapubic catheter?
No, I would say it's not. You know, it's just like you know, in the young child who's not toilet trained. You know, the baby that has, you know, a diaper. I think it's not contraindicated. I think one just has to think about that when it's putting in the PD catheter. Where exactly should that catheter exit site go? As I showed you in that child with the colostomy, where again, that colostomy was a risk for peritonitis, we put that catheter exit site on the chest wall. And in fact, that child who was on PD for 2 years never had an episode of peritonitis. So I think when one has these ostomies or a suprapubic catheter, one needs to work with your surgeon and with the family and sort of strategize where's the best place to put that catheter to minimize the risk of contamination.
All right, for the sake of time, I would like to end this session. Thank you very much, Prof. Brad, for this beautiful work. Thanks a lot again, and I'll handle the mic to my colleague, Dr. Riyad Sali. Thank you very much.
Thank you very much. I really appreciate participating in your meeting.
Dr. Riyad, is mic is yours now.
Assalamu alaikum. Welcome all to the last but not the least session of this scientific symposium. I would like to take the honor of introducing our speaker, Dr. Van Beeson, the chair of nephrology at Ghent University Hospital in Belgium. And he will be presenting on the transition to dialysis from failed kidney transplantation. The mic is yours, Dr. Van Beeson, for all ears.
Thank you very much for the invitation and for the invitation to speak about the transition from transplantation back to renal replacement therapy, PD or HD. The only problem is that I cannot see my slides for the moment, which is a bit annoying. So can you see the slides?
Yes, but you need to be maximize the screen.
Yeah, but that's the problem. It was, but it isn't any longer.
If you can't see it, yeah, it's moving.
That's better, probably.
Yes.
Okay, now I have to move this. Okay, so what is the problem really that we are talking about? Well, we all know that when patients are reaching end-stage kidney disease, that at some moment in time, we will need to decide when they had to start or when they will have to start renal replacement therapy, be it dialysis or be it transplantation. But we also know that patients that underwent the transplantation, be it a cadaveric or a living donor or an old for old program kidney, that they might have a failure of that transplant along their career, along their disease history, and then at that moment they will have to come back to peritoneal dialysis or to hemodialysis. We call this the integrated care program. And we all know that we have to make choices, and we know that these choices are not definite. You're not starting a patient on PD with the intention to maintain him on PD. He might fail PD and have to transfer to HD. You can transplant him, he might fail and have to come back to PD or HD, and the same for HD. So we will have to develop a kind of pathway where patients have the longest survival with the best quality of life possible. Now, when we're looking to transplantation, most of us would consider, at least until 5 or 10 years ago, we would have presented this to patients as the final solution of their problem, and they would be healthy after that. But we all know, of course, due to experience, that this probably is not the case for all patients. And these are data thanks to Johan de Meester, who is the chair of the Flemish Registry of Renal Replacement Therapy in Flanders. And I would refer you to his very brilliant paper in JASON that was published some weeks ago about the management of COVID patients on dialysis. But here you see the results of that registry with regards of return to transplantation. And you can see that, for example, if you look in the red line, which is the cohort that started renal replacement therapy 99-2000, that the 12-year survival of these patients is around 50%, meaning that about half of these patients will still be having a functioning transplant and be alive after 12 years, about half of them. And if you look to the reasons why these patients drop out, well, they either die or they have a failed transplant. And you can see that the number of patients that returns to a renal replacement therapy due to a failed transplant, well, it's around 20 to 25% over a 12-year period. So as most transplant programs have started something like 20 years ago to be fully active, we are now seeing that failed transplantation is becoming a more and more important reason for failure and reason to start dialysis renal replacement therapy. And this is not only in Flanders the case. If you look to the data from Europe, this is ERA EDTA data, you can see a bit the same picture, that after 10 years in the cohorts that can reach up to 10 years, that the survival probability being alive and with a functioning transplant, it's around 50%. And it's the same if you look to the USRDS data, you can see that the probabilities for a 10-year survival, depending on the decade that you started the epidemiological survey, is around 50%. So more and more, this will be becoming a problem, patients that fail transplantation and that come back to dialysis. And it has already been discussed before and published before that the transition from failed transplant to starting again on renal replacement therapy on kidney dialysis or peritoneal dialysis, it's due or it's fraught with a lot of complications and with an increased hazard ratio. And you can see that in the days, so this x-axis, it's in days, you can see that in the first 2 or 3 weeks after this transitioning, when people have to start dialysis, that the hazard to die is quite high. It's up to 10-fold higher than the average risk that these people reach the nadir after 1 year. So that first year after transition, it's really a horrible time for these patients. It's a high risk time, and we need to understand better how this comes and what we can do about it. Now, one of the things that we can observe from epidemiological studies, the people that return to dialysis, they differ from patients that start dialysis as fresh people. So before they ever got a transplant, patients that just start on dialysis without having a transplant, as compared to those who return to dialysis after failed transplantation, they fail in some regards. And some of these things we cannot do anything about it. Like, for example, gender, like, for example, their race. It's not something that you can change. But what we can change is that we see that the access at initiation of dialysis, whether they have a functioning fistula rather than a catheter, it makes a huge impact. It's a reasonable risk factor in these patients that impacts negatively on their outcome. Their serum albumin and their glomerular filtration rate, meaning that we start these patients on renal replacement therapy at a more delayed time point, meaning that these patients have a less good kidney function at the moment that we start them. And we don't even take into account there, because most of these are estimated glomerular filtration rate, meaning that they're based on serum creatinine. And we all know that failing transplants have a decreased muscle mass as exponential or as highlighted here by their decreased serum albumin, because they're becoming progressively more and more cachectic, so meaning that we start these patients at a far longer, far more delayed time point than we would have started them if they would not be failed transplant. There is a kind of horror, there is a kind of aversion to start these patients again on renal replacement therapy on dialysis. And this is not good. This is detrimental for the outcome of these people. So first of all, we have no good preparation of the people. We fail to recognize that they are ending up on dialysis again. We fail to admit that this is the case, and accordingly we fail to prepare them as it should be by giving them a good suitable vascular access, or by preparing them again for peritoneal dialysis by placement of a PD catheter. And this is, of course, one of the things that we should try to improve. And Professor Warade has already explained the quality improvement program in pediatric programs. We should have the same in our transplant programs in the adult population, because we know that there is a gap between the quality that we are striving at in non-failed transplant patients when they start dialysis and the patients that come from transplantation. And again, here you can see that these people have a lower albumin, that these people have a lower likelihood of starting dialysis with a functioning fistula, that these people start with a lower GFR and with a higher comorbidity, all again negatively impacting on the outcome of these people. And again, this is another study from a more recent cohort where again you can see that the patients who have a planned vascular access at start of dialysis as compared to unplanned vascular access at start, that they have a worse outcome. But not only the vascular access is of importance, of course, we should also try to correct or to prevent that these people go too far down the line in terms of acidosis, as expressed here by a lower bicarbonate, by management of their hemoglobin. And of course, you could argue that the lower hemoglobin is partly related to the inflammation that is occurring in most of these people with a failing transplant. But again, it's not a good reason to delay the start of renal replacement therapy, to delay the startup of erythropoietin or other ESA anemia regulating drugs. You can see these people have a worse phosphate control, and these people have a worse blood pressure control. And they have more signs of protein energy wasting. They are more inflamed, they are cachectic, they are in malnourishment, and so forth and so further. So all these make that people that start on dialysis with a transplant that has failed and with inflammation, and that's the majority, have a nearly 8-fold higher risk for mortality as compared to patients that start fresh without a previous transplant in these on dialysis. And the question is, of course, now that we know the underlying mechanisms, now that we know the underlying risk factors, can we do something about it? Can we avoid that people have a higher risk when they come back to dialysis after transplantation? And this has been observed. It's an observational cluster randomized trial in 2 UK transplant centers where they compared one center where there was a dedicated low clearance clinic where they tried to address all those factors that I mentioned in the previous slides, and another center where they had not such a strategy in the beginning. And you can see that at start or at restart of dialysis, there was not a real difference between these 2 centers in these patients. And the study then also concluded accordingly that a dedicated low clearance clinic can improve the counseling and the workup of a transplantation in these people, but it did not result in an improvement in the factors that made these people at higher risk for a worse outcome at the end of the day. So the question is then, is it worthwhile to make this in these people, to have a low clearance clinic for failed transplant? And probably it most likely is, because if you look to the preparation the better information and education and empowerment of these people, you can see that there was a positive impact on the hepatitis B vaccination. There was more discussion on dialysis preference. People get education again, because incorrectly, wrongly, we presume or assume that failed transplant patients, they know about hemodialysis, they know about peritoneal dialysis, but for most of these people, this was from a previous era. It was 5 or 10 years ago that they were on dialysis, and they have already their mind up. They have already some images and ideas on how that might be to be on dialysis, peritoneal dialysis or hemodialysis, but from a previous age, from a previous era when things were different as from what we are doing today. So they need again to be re-educated about these modalities in order that they can make a good choice between HD or PD. But you can see that in half of these patients, this was not discussed in the center where there was no low clearance clinic. And of course, also the option of a retransplantation, which might be important in the selection of, for example, home-based therapies, or in the selection or whether or not to make a new functioning fistula in these patients, was also not discussed in 40% of the patients where there was no low clearance clinic present. So this is indeed not very good outcomes, I think. And we can do something about it, but we need to be attentive, we need to be careful, and we need in the first place to be able or to be willing rather than able to be willing to admit that there is something going wrong with the transplant kidney, and don't wait too long just denying that there is a problem. Because of course we know that patients do not want their kidney to fail, they want their transplant to be functioning, and as long as we as doctors, as nephrologists, as nurses are not going to say, well, there is a problem, they will not admit it for themselves. So in conclusion, so far, I think that the management of failing kidney transplant can be improved with low clearance clinics, but that the majority of the attention should be spent on education to these people that indeed there is a problem, and that probably we will need to restart dialysis, and that they need again education on the dialysis modality that might be preferable for them. And that makes the question, of course, does dialysis modality after failed transplant make a difference? Well, a lot of studies have been done on this, but as you can understand, most of these studies are observational. To my knowledge, there are no randomized controlled trials on this, so we have to rely on what's available, observational data. And this is a very nice, it's not a systematic review, but a very good narrative review on the topic, where you can see that the available studies have been listed. And the major conclusion of these studies is that it's probably not making a big difference whether you start on PD or HD in these patients, and that outcomes are quite comparable, so that it's up to patient's choice and the patient's desires and expectations to make a good choice between PD or HD as the renal replacement therapy of choice. However, of course, in both modalities, there is some caveats if you're treating patients after transplantation. For example, this is data from a single center from London, where you can see that if you compare the control, so patients starting fresh on PD versus the post-transplants, that they tended, of course, to be longer on renal replacement therapy, but that for the rest, there was not much difference in underlying disease. There was not much difference in hemoglobin levels, bicarbonate levels, metabolic control, and so forth. However, the technique survival tended to be worse in the post-transplant cohort. Although, in contrast, the overall survival did not differ between the two cohorts. This means that these patients start on peritoneal dialysis, have a higher risk for technique dropout to the other modality, to hemodialysis, but that this does not jeopardize their outcome. And the major problem here seems to be, of course, peritonitis. Not completely unexpected that patients after a failed transplant who still have immunosuppression on board, who might be immunocompromised by the load of immunosuppression they had already before their failed transplant, might negatively impact on their peritonitis rate. So this is certainly a concern. However, do not forget that infection risk is also a problem in HD patients and might be even more cumbersome, because in HD, it's not a peritonitis episode, but it will be sepsis with the risk of endocarditis, osteomyelitis, and so forth and so further. A second problem that we can encounter in patients on PD after failed transplant is, of course, that the majority of these people will be fast transporters. So they will need a kind of adapted PD regimens, mostly with short cycles, mostly having ultrafiltration failure if you're applying longer dwells. So most of these people will probably end up on a cycler and probably end up needing icodextrin to maintain their fluid balance at the end of the day. This is again data from our own center, where you can see that indeed the percentage of fast transporters after transplantation is much higher than in the non-transplanted patients. So you need to take that into account. And the same observations have been made in the French registry, the group of Thierry Lobedes. You can see here that indeed, if you compare the patients with at least one episode of peritonitis, you can see that there is a tendency that this is more in the transplanted than in the non-transplanted group, but more especially there is an increased risk for transfer to HD, so technique failure, whereas the difference in death mortality as an outcome was in fact not different between those two groups. And if you compare this in a matched cohort, then you see that if you look to the control group versus the transplanted group in the red bars, that the probability of these people to be transferred to hemodialysis after starting PD is bigger, of course, in the transplanted group than in the control group. And you can see the same here if you correct that for competing events like that and a new renal transplantation. You can see again that patients who had a failed transplant have a worse outcome than patients who start fresh on peritoneal dialysis. And if you look to the reasons why these people had to transfer to hemodialysis, then of course it's not a surprise to see ultrafiltration failure rank high. But in this study from the French cohort, there was no enhanced peritonitis risk, which is a bit surprising, of course, and that malnutrition was also not a real problem. So in this group of the RDPLF in the French registry, they did not report any differences in survival or peritonitis rates, but again, as in the previous USRDS data, a higher PD technique failure in the transplant group. This is other data published already 20 years ago, where you can see that, again, the time to first peritonitis episode is, of course, faster in the post-failed transplant group than in the other group. If you're transferring patients to hemodialysis, you have to be sure that these people have a vascular access. And this might be problematic. Although you can see this is data from the group of Louise Moist, you can see that over time there seems to be an improvement in the rates of people that start hemodialysis with a functioning fistula. But you must consider this as a major problem, because of course the risk for infection if you have a tunneled catheter in patients who come from failed transplant might be very substantial, as we can see also in peritoneal dialysis. And this makes the question not only of which modality to use, but it mixes up the question of which modality to use with the question whether or not to maintain immunosuppression and whether or not to remove the failed transplant kidney. Because of course, if you remove the failed transplant kidney in the majority of patients, this will mean that the peritoneal membrane will be substantially destructed and that peritoneal dialysis might probably no longer be feasible, because a lot of these failed transplants have a lot of adherence and have a lot of difficult to remove kidneys, so that the peritoneal membrane might be severely damaged afterwards. So you have to balance the pros, the advantages of maintaining your immunosuppression against the disadvantages of doing so. And of course, having less immunosuppression might mean that you get more inflammation from the rejecting and the chronic rejection that you have in your kidney, but of course you might have less inflammation. So it might be that there is a balance in there in terms of inflammation. The inflammation might cause to have more EPO resistance, might have to cause more anemia, might cause higher CRPs, and so forth and so further. On the other hand, of course, decreasing the immunosuppression might mean that you lose residual renal function, that you lose clearance, and that your volume balance might be less good. So you have to balance preservation of glomerular filtration rate to the higher risk of continuing immunosuppression, skin cancers, lymphomas, infections. And of course, this is a balance that should be made based on clinical decisions and also, of course, on the further fate of the patient. If this is a patient that will be a suitable candidate for a retransplantation, it might be worthwhile to continue immunosuppression because we know that if you remove the kidney, these people have a surge of their antibodies, which might make them non-transplantable for a certain period of time. So this is something where you cannot give one size fits all advice. You need to balance all these arguments in the individual patient. And based on the previous analysis in this study by Sarbit Jassal, they come up with a kind of decision threshold where you can see that the decision whether maintaining the kidney and the immunosuppression is beneficial, yes or no, depends a bit mainly on the preservation of residual renal function. And if you have something like the equivalent of more than 5 ml per minute, milliliters per minute of clearance in these people, then probably it's worthwhile to maintain the kidney, whereas if it's less than that, more and more progressively so, the number of life years that you will gain by doing so will probably decrease until the moment that it becomes even negative in people that have lost the residual renal function of the failing transplant. So this might help you in the decision whether or not to transfer or to remove, the kidney in these people that have transplanted, failed transplant. So their data suggests that there might be a survival advantage in maintaining patients on long-term immunosuppressive function, even after they return to peritoneal dialysis after allograft failure, as long as there is residual renal function present. Now, one of the major things that we observe in all these data is, of course, that we tend to avoid talking about a failed transplant, that we are very much frightened to explain to the patient that there is something going wrong with his kidney and that he might have to go back to dialysis. And this is, of course, because both for the medical professionals, as especially for the patient, the failure of their organ is a source of grief and depression. And this is, of course, because people have been told in the beginning that they would be completely healed and completely recovered and completely in good health again after the transplantation. And they make some stories about that. They have their imagination of a completely healthy body, which is, of course, not true. And we all know, I've shown you that at 10 years, we can expect about 25% of transplants to fail and to come back to dialysis. So we have to make them prepared for that from the beginning. And of course, this goes together with a lot of uncertainty and anxiety, a lot of grief, and sometimes even rebellion against the physician who's trying to tell them that there is something wrong with their organ. And this makes that we delay their restart on dialysis even more than we should do, causing additional harm to these people. And we cannot say that in failed transplants, well, these people have a late referral. We have that excuse in patients with native kidney disease before their transplant because we do not see them often as nephrologists, but the majority of transplanted patients are under the care of nephrologists. And only a minority of grafts are lost suddenly. It's less than 6%. The majority are just a fact of chronic deterioration over time. And this is a problem. So I think these people, and maybe even their treating physicians, should receive psychological support. They need re-education because they have most often bad memories of dialysis. They need a retransplantation planning when that's suitable for them. And we need to be careful, we need to be attentive for their quality of life issues, and there is instruments to measure that. I thank you very much for your attention.
Thank you, Thank you, Dr. Van Bissen. Very informative presentation. You've actually answered a lot of the questions that I actually prepared, or the questions that have been submitted by the audience. I'll start with a couple of questions that I've received, and it's about the management of immune suppression in patients who are back on dialysis, whether it's hemodialysis or peritoneal dialysis. Probably, the general practice is to take off antimetabolites first and keep these patients on small doses of CNIs. Would you recommend that protocol, or do you prefer keeping antimetabolites as opposed to CNIs to minimize the further loss or the fibrogenic effect of CNIs on the residual renal function?
That's a very good question, I think. I'm not sure that there is any true data on that from basic literature or basic science. What you can say is that the long-term negative effects of CNIs are probably less on the immunological side, though at the same time, of course, as you correctly point out, their vascular effects might be stronger. So in that regard, especially in patients on peritoneal dialysis, you might presume that there is a negative impact on their vasculature of the peritoneal surface, and that they might get more and more into trouble, kind of fibrosis of the peritoneal membrane. But I'm not sure that there is really data supporting this view. It's a very good hypothesis, but I don't think in clinical reality we can tell you about that. What is a case, I think that if you maintain CNIs, they have some vasoconstrictive properties also, which we all know that they reduce proteinuria, for example, in patients with nephrotic syndrome, that this is probably more due to their vasoconstrictive and hemodynamic effects rather than on their immunosuppressive effects. And you can have the same mechanism on the peritoneal membrane. And as most of these patients tend to be fast transporters, that it might prohibit them of being too fast, to have too fast transport and preserve their ultrafiltration capacity more. So my suggestion would be, and this is our practice, that we maintain the CNIs and that we build off the other antimetabolites, for example, of the immunosuppression.
Excellent, thank you. I have one more question, if you allow me.
By the way, if you're another point in favor of that would be that you can monitor the blood levels of CNIs, whereas for things like mycophenolate, for example, it's much more difficult, and you have to adapt to those in patients with renal failure. And this is often neglected, making that these people are overdosed in many cases if their renal function goes down.
Yeah. I have one more question, if you allow me. Now, those patients who are back, failed transplant patients who are back on dialysis and considered potentially for another transplant, for retransplantation, do you prefer any dialysis modality for their future transplant or retransplant? PD versus hemodialysis.
Again, a very good question. The data, and this is data from our group already from very long time ago, I think it's the beginning of the year 2000, we have demonstrated that PD as a pre-transplant modality is favorable, probably because there is some immunological effects. There is a kind of activation of the immune system by the hemodialysis procedure, even with the modern membranes, high cutoff membranes, that makes that these our immune system is a kind of chronically elicited, which probably adds to the the harm in the first days after a new transplant, which makes that these people have more delayed graft function. And if you have more delayed graft function, it has been well demonstrated that the longer term outcomes are also worse. So if you look, for example, in the UNOS data, people that are coming from PD as compared to HD, they have a better outcome. They have a better transplant function at 5 and 10 years. So PD seems to be favorable over there. So I think if the patient, but that's always like that, if the patient is willing to get to PD, there is no reason to withhold it from him. Of course, it doesn't mean that if the patient is not willing to do PD, that you have to force him to go to PD because the transplant will certainly fail if he goes to HD. But it's an additional argument. If I would be a patient, I would prefer to be on PD because I know that my transplant outcome would be better, I think.
Excellent. Thank you very much. I think the time for this session is over. Thank you, Dr. Van Besen. And I will hand the mic over to the moderators, Dr. Khalid.
Thank you, Riyad. Thank you very much. Now we move on to Industrial Symposium. That's supposed to be yesterday. So it's my great pleasure to introduce Dr. Ayman Karkar. Ayman Karkar, he's one of the senior nephrologists in the kingdom. And currently now he's holding a position, admin positions in Baxter's over all the regions. So Dr. Ayman, the mic is yours.
Thank you very much, Dr. Khalid. That's very kind of you. And it's my great pleasure indeed to be with you this evening. And I promise I won't be long. I know it's the last presentation. So what I'm going to share with you is what we have seen lately in the literature about remote patient management, or in a way, if you like, the telemedicine for patients, in particular on peritoneal dialysis. So I'm just going to go briefly with an introduction, and then we'll talk about why the non-adherence to PD prescription is important and what are the consequences to that. And then I will share with you what we have seen in the literature lately from the remote patient management data before reaching to a conclusion. So as you know, once patients follow their, catheter insertion and training, they usually followed up initially like on monthly basis, but once they are stabilized, as you know, they will be seen in the clinic every 2 to 3 months. However, as you know, this period might be a bit long to see what patients are going through. And if we look at this situation from the perspective of patients, nurses, and doctors, patients, as you know, may feel when they are doing it at home alone, they lack the supervision, so they may feel a kind of isolation or uncertainty, and then there is the lack of oversight, as I said, and there is a risk of worrying about maybe they need to go to hospital or emergency visit more frequently. So it's always there, the uncertainty about the possibility of complications or technique failure. What nurses really deal with most of the time is they react to what unexpected. They don't know what was going on, and then there are usually some unplanned clinic visits because there is a gap in between. Something might come up during this period. Retraining of patients necessary again, management of late complications. Then they need to provide some time for the new admitted patients, which were unaccounted for, if you like. So there is a more excessive reaction to unplanned activities, and obviously more work on the nursing staff. For doctors, of course, it's important for them for the prescription to be fulfilled, and the non-adherence that may lack the optimization of the therapy. And again, there are unscheduled visits coming and delay in predicting the complications. Again, obviously, there is more of workload on doctors and less time, if you like, to spend on other important work for them. And obviously, this will increase the utilization and consumption of health resources, and needless to say, also have cost implications. So how come we overcome these challenges with the current place when there is no telemedicine or telemonitoring of patients? Well, usually, as you know, nurses keep doing more phone calls, more frequent phone calls for patients to ensure that they are in good condition and there are no problems or issues. Then there probably more home visits. If there is a program of home visits, there will be more of them. This is another burden, but trying again to check on patients if they're doing well. And obviously the record book or the booklet is very valuable, one that patients record all the details and bring it along to the clinic. And when there is more workload, you may need more staff to deal with the reactive work, with excessive work. However, doing this, there are still remaining challenges. For instance, despite the value of the booklet, where the patients mention everything, for example, from the fluid intake, urine output, the drainage volume, the ultrafiltration, everything. But the issue with it is, again, the doctor or the nurse are unaware of them until after second or third month when they come to the clinic, unless obviously there's an emergency. And some patients may find this is quite challenging because they need to do it on daily basis, regularly, and they may not comply with filling, if you like, the booklet data. Another thing, sometimes patients feel a bit, guilty. So when they come to the clinic and they did not fill the data, may fill it outside the clinic before they enter and see the doctor. So you may find some unusual figures there. And the worst part of it is sometimes the patients come to the clinic and they forgot to bring along with them the booklet. So what the Home Choice, when was developed by Baxter early on, then was developed to more the Home Choice Pro, where there is a SIM card, a very similar one that we use in the mobile phone or in the, as you know, the cameras, for example, and it's supposed to record these details. However, again, this issue is some patients also, they may not bring it along with them, they forget it, or also if they come to the clinic, again, they need to bring it every second or third month to come to the clinic. And so again, this is the lack in the period to see what was going on during this period. And the worst of all, also doctors may be too busy to stick this in the computer and analyze the data. So you can see from kind of the practice of PD, when there is no telemonitoring or management, there are a lot of unmet needs, but probably one of the most important one of them is the unawareness of patients' adherence to prescription. So we don't know what was going on, if they do adhere to the prescription or not. And Judith Bernardini early published a number of studies on that and showed that non-adherence is defined as performance of less than 90% of prescribed exchanges. And if there is a kind of non-adherence, this is significantly associated with a lot of risk factors, like, for example, the technique failure, peritonitis rate, hospitalization, and days staying in hospital. And again, the rate of death is significantly increased. So it's not easy to leave a patient non-adherent to the treatment. And also they have shown that 30% of patients showed non-compliance, especially in the first 6 months of PD treatment. And this is, for instance, when they looked at the KT over V, for example, what was delivered was only 18% versus what was prescribed. How common is this non-adherence? This is, in fact, I've been searching for different studies, but I found this one is a very nice systemic review. And this paper looked at, well, 204 studies. However, only 25 of those were met the criteria set up in this paper. And as you can see, is up to 53% of dialysis patients, they miss on dialysis exchanges, and up to large percentage on medications, and up to 67%, 2/3 for diet and fluid restriction. So this is something not uncommon. It's important thing to monitor. So how can we do that? Maybe the best way is to look at there is the system of telemonitoring, like what is in share source process. So what is share source? Well, basically the share source is a cloud-based software, which if you like, uploads all the treatments after each dialysis session where the patient is home, carry on or upload all the information and then transfer it to the hospital where the doctor and nurse can monitor what was the patient is doing. This can be done, as I will show you, on daily basis, weekly, monthly. You can monitor all those data. And this is a two-way communication system. So it's not only the information passed from the patient all the way to the hospital, but equally important for doctor nurse, if there is a change of prescription, can also be done remotely. So they don't need to bring along the home choice or the cycler to the hospital. And how does this work? At the back of the home choice, this Clario with share source, at the back you connect a modem, and this modem usually either there's a SIM card like the one in the phone or a landline phone. So you don't need internet in areas where there's, for example, patients don't have access to internet. So it's simply, but at the patient in the hospital, doctor nurses usually have internet connection. And how does this work? As I said, after each session of dialysis, information is transformed to the doctors and nurses, and they can monitor, if you like, this like platform comes on the screen. And as I said, this can be seen on, like, for one patient, many patients at the same time. You can look at daily, weekly, or monthly, monitoring. And this is a system which, if you like, draw the attention of the doctor or nurses by flag system. And those flags, either they are in green, means that treatment completely and everything is fine, or sometimes you see it like a yellow, like here, for example, a flag. This means there is a priority flag, or sometimes it's red, it means high priority flag. And this tells you about if there is any loss of treatment time, or lost dwell time, lost therapy volume, or drained ended early, for example, or for example, there is a drain or dwell bypass over that. Obviously, there are other signs, for example, plus if you want to add patient or remove patient from that list, for example. So if, for instance, you've seen like a red flag, you just need to click on that red flag, and it tells you, for example, what the situation is, that the drain ended early. So you know that the patient's finished or drained early before completing the cycle. And in addition to the data, what it gives you, the number of cycles happening, and all this in each cycle of those three, for example, you see on the x-axis here, it gives you the time in minutes, and this is give you the volume, how much is like fluid fill in the peritoneal cavity. So for instance, here you see in the first here, the fill volume, this is represent the filling, and this is the dwell time, and this is the drainage. And here you can see like the fill volume is 2 liters filled, and this time it took about 10 minutes to fill. And this is the dwell time, took about 90 minutes. And here you can see the drain, it's like draining over the time from here to there, about 20 minutes. And when it goes below that, means this is the ultrafiltration, the excess. This is you fill 2 liters, for example, here the extra, like 2 liters 300 ultrafiltration. So it gives a nice way of fill, dwell, and drainage. So if there is any abnormality, it gives you something like this. Is one example. Here you can see in this cycle, there's a very good fill, dwell time, very nice, and then it's draining. Second, the third cycle, you can see there is a delay in the drainage. And this is when it was the patient was called, the patient had constipation, there was delay in the drainage. And in this patient, for example, there was a fill, there's a dwell, and then there's delays, more delays, and then it looks like the treatment was stopped, or the treatment. And this is short later on when the patient was called, patient had catheter blocked with an omentum. So you can see this data which reflect what is going on here, shown in the graph. So does this shared source help? Does it have any impact on non-adherence? Well, indeed, yes. Feranek et al. In 2017, they studied if the clinicians have the choice or the ability to monitor patients on those APD with this shared source, will they be able to have more visibility on the adherence of patients or not? And what, in fact, they looked at European patients, about 400 patients on APD therapy for 3 months or more on this home choice Clario with shared source, and they were monitored on daily basis and every week. That's up to 6 weeks. And what they looked here, like, for example, from the time they start to look at the time on treatment from the first treatment after the training is completed until the last recorded treatment. And also they looked how much the number of performed treatments per week. So it's not daily, they looked on weekly basis. So the best way to look at the calculate how much the number of treatments per month, let's say, for example, 27 treatments per month, and they divide it by 30 days, which is a month. And then it gives you per day 27 divided by 30, give you something, a figure. Then you multiply it by 7, which is a week. It gives you like 6.3 treatment done per week there. And then you look how much is the actual versus the prescribed treatment time. So obviously you need to see how much was missing by how much was the prescribed and how much performed, so you can tell how much was missing in this treatment. And this is what they have shown. On the y-axis you see the number of patients, and on the x-axis you see the number of missed treatments. And those bars represent also the percentage which coincide with the number of patients. So look, the number of missed treatments in the first month on dialysis, see there's 41% didn't miss anything. They were completed very nicely, but those were more than 160 patients. Remember, 399 patients the total. And those who missed one treatment were 16%, that's about 60 patients or more than 60 patients, and so on and so forth. You can see here those missed 5 to 8 account for 13%, and those more than 9 account for 12%, more than 40 patients. So if you look for missing more than 4 treatments, accounts for 30%. That's a large number. And if you look how much the time, the missed time treatment per week, this is on weekly basis, week 1, 2, 3, 4, and the darker green represent those patients missed more than 100 minutes. You can see 97 of those patients, and those missed more than 200 minutes, there were 50 patients, and those missed more than 300 minutes, 38 patients. So you can see isn't the consistency over the 6 weeks, the same almost number, they're missing a good number of treatments. And when they looked at the dwell time on those patients, again here you can see the green, darker green bar represents missed more than 5% of the dwell time. You can see more than 180 patients, and those one missed more than 10%, and those missed more than 15, and those more than 20%. And if you look as a general on all of them, you can see the percentage of all those patients missed during all the 6-week period. 43% missed more than 5%. 21% missed more than 10%, 12 more than 15, and 7% more than 20%. So as you can see, 40% of those patients missed more than 10%. So this is where they're achieving less than 90% of the adherence, if you like, and there were the risk, if you remember. So if you have a chance to monitor those patients and manage them remotely, it helps the physicians to see things early on and react proactively. So they don't want until the complications happen, the patient come to emergency room, can react early on and the timely manner manage those patients. So is there any evidence for that? What happened? How does that change? Well, this is a very nice study done in UK. And they were like reviewing nurses before and after, over 2 days, before shares and after share source. And they looked at the tasks, how much they are doing tasks, whether they do direct to patient task or indirect one. And they look at the proactive, they went predicting things beforehand, and reactive when the problem happens, and what is the routine work is being done. And what they have seen in this result, amazing, the number of before the share source, before the remote management, you can see the proactive was only 2% here. After the remote management, this significantly increased to 37%. The reactive decreased significantly from 45% down to 28%. Even the routine work decreased in those patients. And this has implications I will show you in a minute. This work has also been documented by Wood et al. Later on 2019, and showed here again patients on APD before they shifted on with the share source telemedicine monitoring. And again, the proactive was 2%, similar, likewise increased to more than 34%. And even the reactive decreased from 46% down to 27%. So you can see the value of the remote management on providing more time for the nursing staff in doing more important tasks, if you like, or direct tasks. And not only that, but looking at the number of annual visits for patients before and after share source, you can see the number of visits before was annually 6.5 visits, dropped down to 4.3, and the time spent in the clinic decreased almost like 50% or so, 55 minutes down to 34 minutes. So obviously that gives more time for the nursing staff. And this is what they shown with it all. If you look here on the left of this graph side, you can see the different types of activities. And this shows what is the value of activity, the score. For instance, training patients obviously scored high, 128.9. This is very important task. And you go all the way down to writing emails or letters, still important, but receive a lower score. And on this one here, seeing how much minutes and the percentage of those minutes by the nursing staff to complete those tasks. This is before the share source and this is after the share source. So here what you can see, for example, for this important task, usually they spend like 32 minutes. This went down to 27 minutes after the share source, and they were 2.3% down to 1.9%. To cut the story short for you, look at the total here. You can see what were 453.7 or almost 54 down to 36 or so. So there's a lot of saving on time for important tasks that nurses can focus on managing patients. And generally speaking, what they found, there was a great satisfaction for doctors, nurses, and even patients by doing these procedures. So does that has any clinical relevance? So it's a great value. We monitor, we can see and we control maybe the non-adherence to the patient. But does that have any clinical relevance? Well, I will share with you what I have seen from the literature lately. A good number of publications came out about that. And maybe one of the earlier one came from Sabrina Manani from the Claudio Ronco group from Italy. And what they found here, they compared patients on APD before and after the share source or remote patient management, and they look at the night alarms, the hospital visits, and direct and indirect costs. So there were 42 patients before the share source monitored for 1.5 years, and around 43 patients again for the same period monitored after the share source. And what they have seen here, you can see this is the bulk of patients who were on a treatment remained on the APD, 76%. And when they were with the share source, they were 84% remained on PD. This is the number of patients who died, 7% down to 4% with share source. Transplanted patient, the same, 5%. And this technique switch from 12 down to 7%. That did not reach a statistical significant, probably because the number of patients in the study was relatively small, but you can see the trend on all of them that they drop down for like 24% down to 16%, the technique failure from 12 to 7, and as I say, the mortality from 7 to 4%. But what was more significant notice in this study is the alarm, which was like used to be before the changing, of the program remotely, used to be one change, the program can change to 2, so they are monitored early. And then in-person visits decreased from 5 to 4. That's again document earlier studies. And the night alarms decreased from 2 to almost 1. What also more important again, the time, the spending with the doctor in the clinic dropped down from 20 minutes down to 8.5 minutes. That's highly significant. And again, the nursing spending time with nurses, again, 50% drop from 30 minutes to 15 minutes, again, highly significant. So you can see the time saving for doctors and nurses, 42 hours for physicians and 28 hours per year. This has allowed doctors and nurses to do and see more or provide more care for other patients. This is one of the recent studies. This is a combined from Turkey and Italy. You can see Dr. Yeter and Claudio Ronco from 2 parts. And here, though the number of patients were small, relative 15 patients, but they were studied over 6 months, and they will look at the adherence to the treatment, the adequacy, the change in blood pressure, the sleep quality, and health-related quality of life. One nurse was able to manage 15 patients within 45 minutes, looking at those platform on the share source. And what was important to monitor was the important alarms, those flags I told you, the high priority ones, the ultrafiltration profile, initial drainage, blood pressure, and body weight. And they used to assess the quality by using the ISN, the short form 36. And here were the results, what they documented about the mean arterial pressure, the KT over V, the ultrafiltration, and the antihypertensive medication. Here, looking at the mean arterial pressure, as you can see, this is at time 0 before starting on the share source, and this is afterwards. This is 3 months and 6 months. They also have data from their record, the record of those patients 3 months earlier and 6 months earlier. So you can see anyway, after starting 6 months, you can see the significant drop in the mean arterial pressure, better control in arterial pressure. And even if you compare 3 months before or 6 months before, so like 9 months, again, there is a significant reduction in the mean arterial blood pressure. Looking at the adequacy, KT over V, again, after 6 months, significant improvement of KT over V. And this is again significant when you compare it 6 months earlier or 1 year earlier before the share source. And these data, just briefly looking quickly, I highlighted them for easy, quick look at. The KT over V increased from 2.11, this one, up to 2.25, and that was significant. Again, the ultrafiltration increased by about 24 ml, and it was again significant. The number of antihypertensive medication decreased, and as I said, the total number of medication decreased. And that's important, you know, the compliance of patients with the number of tablets they take on average. We published that before, about like 19 on average daily, and there is lack of compliance of medication. So when you decrease the number of medication, that helps patient becoming more compliant with medications. Looking at the alarms, here each patient number 1, 2, all the 15 patients, and each of those bars represent the duration they monitor. This is the blue one at month number 1, the other, the orange one at month 3, and the gray one at month 6. So if you focus on the gray one, you can see not many of them really elevated, even disappears from the number of those patients. But in summary, at the start, you can see here they're varying the alarms between 8 to 3, and then at the end of the study, 6 months, vary between 3 to 0, nil in some patients. But on average, you can see the significant reduction down to 2 in this study. This is a very nice study, though it's not yet published. It came as an abstract from the recent virtual EDTA conference. And here they looked at this study. This came from Colombian registry and over 2 years follow-up period. And they looked at the technique failure rate, and they looked at peritonitis rate, whether patients have the remote patient management or without remote management. And a good number of patients, 148 in each group. So you can see there is a significant reduction in the technique failure when patients on the remote patient management from 0.15 down to 0.07, and that's significant. However, the peritonitis rate, although there was a trend of reduction, as you can see, but that did not reach statistical significance. However, if you look at the number of reasons for technique failure, you can see the value of share source or the remote patient management. For example, reduction in peritonitis or infection, there were number 7 here, whereas only 4 without the remote patient management. Loss of dialysis adequacy, only 1. There were 5 there. Catheter problems, only 1 here. There is 4 there. Psychological medical issues, only 2, and there versus 7. And patient desire, 0 here, where are were 2. So you can see total there's 11 reasons for technique in general, for reason technique failure, 11 versus 22, like 50%. So the message here, there is a 56% reduction in technique failure when patients are having the chance to be monitored remotely. Looking at the impact of share source on or remote patient management on hospitalization, this is from the Sanabria group. And then what they looked here at the number, there were like, this is a multi-center study, 28 centers over 1 year, and there were 63 patients group. They were followed. They were before more, but those met criteria. There were 63, and there was 39% reduction in hospitalization. That was significant, by the way, and days staying in hospital, reduction of 54%. And there's no wonder why is that, because with remote management, there's better adherence, better blood pressure control, as you have seen, better achievement of ultrafiltration, early detection of catheter dysfunction. So many factors that can be predicted early on and managed and helps avoiding the hospitalization or staying longer in hospital. What about healthcare resource utilization? Would that be benefit of at all? As I said, by reducing hospitalization and days staying, obviously that has cost saving implications. This is a very nice study done by Makia and a group. They're coming from different units from United States, from Germany, from Italy. And this is a simulation study, in fact, where they look at the mainly focus on unscheduled visits and complications. And this is, in fact, I'll show you the centers conducted, but they have like simulation of 12 APD patients with or without shared source. And there were 11 teams made of nurses and nephrologists monitoring, have experience with remote patient management. And they looked at the resources considered here, where there is a saving or not on this, or utilization, unplanned clinic visits, emergency room visits, hospitalization, clinic calls, and so on and so forth. And here you can see that those participating, those from United States, there were 7 clinics, from Germany 3, from Italy 1. And if you look at the number of patients, you can see a good number here, 82 patients, 48, 80. But what's more important, the years of experience with automated management of patient automated PD. There's 17 years from United States, 21 years Germany, and 27 years in Italy. So you can see a good background. And what's this study shown by this simulation, giving the same patient, the same history, the same problem. Just briefly, I will show you here this patient without remote patient, with remote management, there's no share, so just doing APD. This 20 years old patient with end-stage renal disease, background nephrotic syndrome, using 2.27, the solution. And this is a student in the university living alone on the campus, and he has access to a mobile phone, and he has a landline phone, but he's living far from his parents or family. This is one day, felt quite dizzy and just about to faint, in the lecture room. He called, I left a message to the unit that he felt so. Though the units came back and called a few times, he wasn't reached. And one day he was playing football after a couple of days, playing football outside, and he fainted and fell down. He was taken to the near emergency room. They did what was needed, then discharged. And then he called, and they get communicated with the units, and they told him, well, you need to come and seen in the clinic. So that was unscheduled planned visit. They obviously called the emergency room to find the background about the patient, what happened that day. And then they come back and they found that he was overprescribed with 2.27. It was excess ultrafiltration. They checked the blood pressure was on the lower side, the weight was on the lower side. And then they asked him to come on weekly basis to check on the clinic until he stabilized. So that created a lot of work, was unnecessary when we compare, for example, the patient, this very same patient, but was on remote patient management or telemonitoring, where the nurses immediately, when they checked immediately after that session of dialysis, they noticed there is a lower weight, and like the targeted one, the lower side of blood pressure. The patient was called as only to change from 2.7 to 1.36 and done within the first same day. So they didn't necessitate all that hustle, if you like. And what they have found from the saving from the type of resources, from clinic calls, unplanned visits, room visits, and if you take all of them among them, there was estimate up to saving of 2 hospitalization, up to 4 home visits, 5 emergency room visits were saved, and unplanned clinic visits were 8. Not only that, but they looked also at the cost, and this is represent the hospitalization cost, and this is the emergency room cost, and this is the switching to hemodialysis. And in the United States, their results came saving per patient about just less than $2,000. And in Italy, that saved them more than $530. And in Germany, saved the patient more than $870. But if you look mainly on the saving from hospitalization in particular, and also the emergency room, if the patient need to be admitted, let's say for a few days up to a few weeks, in the United States, they calculated saving more than $23,000. And in Germany, more than $11,000, and Italy, more than $7,000. So obviously that has really reduced healthcare resources utilization, and a lot of saving can be done. This is another simulation study by Yoshiyama from Japan. And what they looked at, the same way, they simulate the same 12 patients, and they have a team of 8 nephrologists, 4 nurses monitoring that, and whether with or without remote patient management, they adjusted the scenarios of cases like what they have before and what suits them in Japan for APD patient, what used to see. And as I said, they looked with or without remote patient management. And what they have seen here, amazing. If you look at the data here, the number of unplanned hospital visits, for example, from 11.3 down to 2.3 when you have remote patient management. The emergency room visit decreased from 5.3 to 0.5. Home visits from 5.8 to 0.5. Even the phone calls amazingly went down from almost 58 down to 18.5. So all these statistically significant, those changes. And when they calculated for an average stay for patient in Japan, like for 20 days in hospital, that was a cost saving of $5,000. And what you see, the resources consumption decreased down from more than 107 down to almost 37, and that was significant. So there is a value for that. This is a recent study. This is Professor Martin Wilkie noted on that earlier. This came from the Colombian registry as well by Ariza. And what they look here at the Markov chain model of structure. And what is this model? They take in consideration what are the possible, if you like, scenarios for patients on PD. So for example, when the patient here are under control, there are no complications, everything fine, they are okay in this circle, for example. But sometimes patients, as you know, they may need to be admitted to hospital for whatever reason. So that's cost. But when they are treated, they may come back again to being under control. So, but the cost, how much that cost will be calculated. And then patients may go on developing peritonitis, but maybe that's treatable and they go back under control, but there are costs here. However, patients who do not go back under control, those obviously who died or there was technique failure of whatever all causes. So there's no need to do any calculations here because they don't go back to the control. And this, when they did this study, they assumed there were like 100 patients and monitored that for 1 year. Obviously based on their monthly previous records of those patients. And if you look at the cost savings here, if you look, for example, patient here with remote patient management, and this is without, and this is the difference in the cost. So here initially for the cost of the treatment, you can see patients with remote is more, in fact, than without. And there is more by more than $62,000. And the reason for that more, because there were more patients taking incident patients and the cost of the modems included. So that explains why, at least in part, why that was more expensive by more than 62,000. However, looking, as I said, hospitalization and treatment from peritonitis, you can see a lot of saving. Here you can see with remote management was much cheaper. There's by less by more than $175,000. And for peritonitis, saving more than $6,000. So if you look at all, even the technique failure, but if you look all of them at all of them, you can see there is a saving for more than $120,000 per those 100 patients per year. But if you look per patient, it was saving more than $1,200 per patient per year. So it is definitely less utilization of the resources. One final thing which our colleagues in the previous talks mentioned, the value of PD, it comes when you have the ability to monitor patient. Patient can still do the treatment at home, but if they are protected or supervised with remote patient management, that can be an added value. And this is showing a lot of studies came on that, but I just briefly mention some of them. This is showing the earlier experience of COVID-19 in north of Italy, Lombardy. And you can see here patients on hemodialysis, unfortunately, suffer more, as you know, or you would expect from the mortality rate or risk on hemodialysis patient, 8% versus only 1% for patients on PD. And then you can see this is from the group from Claude Rionco, Sham from United States, from New York experience, and from Italy, putting algorithm on how to deal with that. And this is, you've seen earlier, this slide again from eminent figures published this from Claude Rionco and also Professor Edwina Brown and others. They put like an algorithm how to manage those patients and where it comes for remote patient management. But for the sake of time, I will not mention it. These are available on those papers online, free, accessible. But this is the experience shown from this in particular study shared by them. But reflects what was in Italy. This is a big region of Veneto, for example, region where it's almost 5 million population, whereas in Vicenza, where Claudio Ronco works, for example, there was 500,000, 500,000 population. But I would like to draw your attention to the number of patients on dialysis they have. In the whole of this region, there were like on PD almost 500 patients, but in the Claudio's Ronco unit, 130 patients. By the way, all of them on remote patient management, the shared source. Those on hemodialysis, more than 1,800, or here 170. But to see those patient number of positive COVID-19 on PD, there is only one patient here, one patient, whereas the 3 there. But on hemodialysis, 33 versus the 3. So you can see PD helps very much. But what they alluded in their publication, they say this report adds to their usual management before, because all the 130 patients were on shared source. And they say there's a considerable reliance on remote patient management strategy, because they didn't change anything from last year to this year. They kept the same rate of, for example, and this patient, in fact, like I think got infection from his daughter from home. And they said certainly the use of telemedicine and remote management tools has allowed us to continue an optimal care of PD patient without significant increase of complications or technique failure. So it was the same practice like of 2019 to them. And even as you have seen the ISPD guidelines, the COVID one 2020, again recommending the remote patient management, and in particular, they strongly say if there is remote patient management, when recommended as a major way, if you like, manage patients on PD in this period. Even the British Renal Association strongly recommended the availability of remote monitoring, like, for example, the share source would be utilized to support communication and streamline stuff. So what's left for me is just to share with you the conclusions at the end. And as you've seen, share source or the remote patient management provides daily monitoring, ensuring delivered prescription and better adherence to treatment, so avoiding all the possible consequences of lack of adherence, and then opportunity for early intervention, education, or retraining. But what matters, timely manner, early on. So we don't want to wait until these complications happen. And this is an approach for improving clinical outcomes, reduction of healthcare resource consumption, and cost saving, as you have seen, and the great value in pandemic situation like in this COVID-19. Thank you very much.
Okay, thank you, Dr. Ayman, for sharing with us an important topic and aspect related to peritoneal dialysis patient management. Thank you, Dr. Ayman, again. And I think we come to the end of this symposium. So on behalf of Society of Nephrology and Transplantation, I would like to thank all participants for their really active participation in this symposium. And I hope everybody enjoy the content, scientific content of this symposium. And also I'd like to thank all speakers for the excellent talk, and our moderators for the active participation in this symposium. And at the end, really, we have to thank our colleague in Baxter Company for sponsoring this symposium, and also the technical support that we get during this symposium was an excellent. And really, on behalf of our society, I would like to thank our colleague and even Troop Company for their excellent dedication and support for this symposium. I think we have to stop here, and I hope we'll see you, inshallah, soon in another meeting and conferences. Thank you, everybody, and good night.
Thank you very much. Thank you.